Good morning, and welcome to the 16th Annual Sentinel Initiative Public Workshop. I'm Mark McClellan. I'm the director of the Duke-Margolis Institute for Health Policy, and I'd like to welcome you on behalf of our Duke-Margolis team who helped put together this event. As you all know, over time, the Sentinel Initiative has continued to evolve. This annual workshop, now in its 16th edition, provides an opportunity to gather members of the Sentinel community along with experts and other interested parties to share key developments in the initiative from the past year and to discuss ways to advance the initiative's engagement, collaboration, innovation, and impact. Today's discussion will provide updates on the initiative's research and analysis that is now an integral part of informing the FDA, stakeholders, and the public about the use, safety, and effectiveness of medical products. This includes work in such areas as the real-world evidence data enterprise and potential uses for AI, vaccine safety and effectiveness, and the shaping of Sentinel System version 3.0. The growing and diverse community and users involved in the Sentinel initiatives remain critical to the success of this public-private collaboration. By adding to the Sentinel initiatives understanding of key activities and achievements of the initiative, the goal is to provide insights on what's been accomplished and the possibilities ahead, and to foster discussion about those future activities as we continue to work to improve the safety and effectiveness of medicines for all Americans. Duke-Margolis is convening this workshop under a cooperative agreement with the U.S. Food and Drug Administration. The discussion today, while supported through a cooperative agreement, is not a federal advisory committee. We will not be voting, making recommendations, or taking other binding actions. We'll be successful if we have a full and free and clear discussion, and we've got a full agenda of presentations and panel discussions to drive that experience today. We're going to begin with a keynote presentation from Dr. Patrizia Cavazzoni. I think we may have an agenda slide that we can put up there. Next, we'll hear from Sentinel Initiative leadership in a fireside chat to get a high-level overview of major milestones to date across the Sentinel system, the Biologics Effectiveness and Safety System, known as BEST, and the National Evaluation Systems for Health Technology, known as NEST for medical devices. Afterwards, we'll hear about some of the accomplishments of the Sentinel Initiative Center and the Sentinel Innovation Center, the Sentinel Innovation Center, and the Sentinel Operations Center over the past year. Then a short break, and we'll resume updates from the Sentinel Initiative with the regulatory impact of the BEST system, including recent vaccine safety and effectiveness activities. After lunch, we'll pick back up with the Sentinel System updates again, hearing about Sentinel System 3.0 and a look into the new contract recompete for the program. From there, we'll hear a bit more about BEST on their use of technological advancements and their vision for the future. Then, after a brief break and before our closing remarks, we'll be hearing from a variety of perspectives in our session on future opportunities for the Sentinel Initiative. Now, I'd like to turn to our Statement of Independence and then some final logistical reminders before we get started with the meeting. The Duke-Margolis Institute for Health Policy is part of Duke University. As such, we honor the tradition of academic and independence and free discussion, open exchange of views and findings. Neither Duke nor the Margolis Institute take partisan positions, but individual participants in our event should be free to speak their minds and express their opinions. And I also want to remind that I'm an independent director on the boards of Johnson & Johnson, Cigna, Alignment Healthcare, and Prognomic. My full disclosures are on my website. Finally, a few meeting reminders. We're encouraging everyone attending, whether you're in person or virtual with us today, to contribute to the meeting through the Slido Q&A function. We and the FDA want to make these discussions engaging and responsive to the community that's gathered here today in person and online, so please don't hesitate to submit questions and comments. We'll pass along these questions and comments to our session moderators, and we'll try to incorporate as many as we can into our discussions. And please join the conversation on LinkedIn as well. You can tag Duke-Margolis when sharing content related to the workshop. Now, to really kick us off, it's my pleasure to introduce our keynote speaker, Dr. Patrizia Cavazzoni, the Director of the Center for Drug Evaluation and Research at FDA. Patrizia?
Good morning, everyone. It's a real pleasure to be able to join you today and to kick off this annual workshop. My apologies for not being able to be there in person today. I'm traveling, but it is nevertheless great to join you all live. I am really delighted to be here today because this is a particularly exciting time for the Sentinel system. And we are on the cusp of changes in multiple ways. When we cover when it comes to CEDAR Sentinel system, we have completed the work described in the 2019 5-year strategic plan. We have done a lot of work to study and adopt machine learning and natural language processing capabilities. And we have advanced analytics to support pharmacoepidemiology studies. We have also onboarded Medicaid data and established mother and infant linked resources, and this will help us better understand infant outcomes after pregnancy exposures. With these accomplishments behind us, we're now pivoting. We're moving from developing capabilities to putting these capabilities into action so that we can address a broader range of safety issues. So what does this mean for the future of the Sentinel system? When it comes to the CEDAR portion, I'm going to highlight 3 main points: narrowing the focus, greater adaptability, and responsiveness to changes in funding. So let me start from the first point. Our intent is going to be more focused. We will have less emphasis on building new capabilities, and we will concentrate on continuing to fulfill congressional requirements, user fee commitments, and post-market drug surveillance priorities. At the same time, our approach will be more adaptable. We intend to be more flexible in how Sentinel will tap multiple data sources and data types. And we will use these data sources to improve our active risk identification and surveillance approaches. We also want to increase the granularity of the data that support our regulatory decisions. We want to leverage advanced analytic methods to abstract data from medical records, and we want to apply advanced statistical methods to conduct inferential studies. Our future data needs for the Sentinel system include health insurance claim data, which are currently the backbone of pharmacoepidemiology studies, as well as insurance claims data that are linked with EHR data. This will leverage the completeness offered by claims data while enriching the clinical granularity through EHR data. We're also open to a spectrum of additional data types based on their utility to address regulatory needs. Simultaneously, we need the new Sentinel system to be responsive to the realities of our budgets. This means responding to year-to-year budget fluctuations by expanding or contracting the Sentinel system to be responsive to regulatory needs based on the available resources. We will establish the infrastructure with the expectation that some of these capabilities will be tapped when the regulatory needs arise and when funding is available, as we saw during the COVID-19 pandemic. This approach will position CEDAR to dial up additional data capabilities as needed and to dial back when specific data sources are less fit for purpose or when funding is more constrained. Long term, it is Sentinel's best interest to have an adaptable approach that allows it to evolve to meet the challenges of changing data landscapes and budget allocations. I don't want to gloss over some hard truths. Data costs money, and funding levels for the Sentinel system, coupled with rising costs, are a constraint to our ability to leverage the full breadth of data sources. Nonetheless, we are working to position Sentinel so that we can continue to protect and promote public health through effective and efficient post-market drug safety surveillance. I want to reiterate that we are at a very exciting time. We are applying the innovations that we have acquired through our last 5-year contract. The Sentinel system will continue to integrate real-world data from multiple sources. We are positioning Sentinel to be more adaptable and flexible, with additional capabilities at the ready to be leveraged as regulatory needs and funding align. And we foresee a future where the Sentinel system can continue to support CDER's regulatory decisions through comprehensive and reliable safety information. I want to thank you for registering for this workshop and for sharing your time in support of the Sentinel Initiative. Now let's turn to the first presentation. Thank you.
All right, thanks, Patrizia. Thank you very much for kicking us off. Sorry you can't be here in person, but I know CDER is well represented. We get some of those representatives up to the panel right now. I'd like to ask our speakers for our first fireside chat with the Sentinel Initiative leadership to come on up. Gerald Del Pon is Director of the Office of Surveillance and Epidemiology at the FDA Center for Drug Evaluation and Research. Steve Anderson, right next to me, is the Director of the Office of Biostatistics and Epidemiology at the FDA's Center for Biologics Evaluation and Research. And Denitsa Marinatsa Dabish is Associate Director, Office of Clinical Evidence and Analysis at the Center for Devices and Radiological Health. It's great to see all of you again. So as I mentioned, we do want to try to incorporate questions or comments from all of you. Hopefully you got the Slido and can submit those questions and comments. I'll try to incorporate as many as I can, but I'd like to get started right now by turning to our speakers to lead off, and Gerald, maybe just picking up on the CDER comments from Patrizia. Could you talk a little bit about some of the key accomplishments of the Sentinel Initiative, the Sentinel System, since the last annual meeting?
Great. Well, thanks, Mark, and thanks for Duke-Margolis for putting this on. It's once again a pleasure to be here at the 16th public workshop on Sentinel. It's hard to believe it's the 16th annual one already. So we've been asked to speak about the accomplishments that we've made over the last year, including some important regulatory outcomes. And you'll hear a lot about these things throughout the course of the day. But we've also been asked to speak about where Sentinel's come from, where the initiative is now, and where it's going. And so in the Sentinel Operations Center presentation later today, you hear that we've so far completed 82 analyses in 2024. That itself is a big accomplishment. You'll hear about work on the evaluation of serious infections following ustekinumab in patients with Crohn's disease. They'll describe a study assessing the incidence of interstitial lung disease among users of vedolizumab and natalizumab. And they'll update us on work on the use of armodafinil and modafinil during pregnancy and assessing the risk of non-cardiac congenital malformation in infants. So stay tuned to hear about that later today. We're also pleased that we're going to hear about a lot of exciting work from the Innovation Center, work that they've done on developing innovative new approaches and methods. But to understand all this, let me just take a step back to show where Sentinel came from, where it is now, and where it's going. So Sentinel was born basically in 2007 out of the need to go beyond individual case safety reports. We did use epidemiologic studies back then, but they were one at a time. We needed something much more flexible. And so in 2007, Congress passed the Food and Drug Administration Amendments Act, which required FDA to build an active surveillance and risk analysis system for FDA-regulated medical products. The answer to that was Sentinel. As I said, before that, we'd been using individual case safety reports. They have limitations. I will also add, though, that they're very valuable. 50% of our post-market safety label changes are based on these adverse event reports. So we're simultaneously developing better methods to look at and evaluate those, but those aren't the topic of discussions today. So Sentinel was launched at a meeting similar to this in 2008, and it's evolved from what was then a bold concept into a comprehensive drug safety surveillance system. We launched what we called Mini Sentinel in 2009. that was the first 5 years, was really a development phase. We worked with our partners at Harvard Pilgrim on this pilot to develop the foundational elements, and importantly, they were able to put together a large group of partners, including healthcare providers, academic institutions, health insurance plans. And through this, we were able to demonstrate the feasibility of using a large distributed healthcare databases for safety surveillance. In 2016, we formally incorporated, CDER formally incorporated using Sentinel in its post-market drug safety assessments and regulatory work. At that time, things were based largely on claims, and we realized as powerful as this system already was, it needed to be more powerful. So we needed to branch out into other sources of data. So we put forth a strategic plan to further develop and refine that system. And in 2019, we launched the Sentinel Innovation Center, and you'll hear about some of their work later today, showing approaches that can use data from electronic health records with natural language processing, artificial intelligence, and a more sophisticated analytic method. So I think there's really been a lot of accomplishments there, and we want to take advantage of them as we move forward. That's why we did them. And so at the annual meeting last year, we announced that we were going to be postponing the next Sentinel 5-year contract that would normally have come to its end about 2 months ago, or on September 30th, 2024. We delayed this by a year to allow CDER additional time to develop all the technical requirements needed to enhance the data and service package available to FDA, based in part on what we've learned from the Innovation Center. So as Patrizia said in her opening remarks, we're going to continue to evolve. Our focus will be less on developing new capabilities, but rather using the capabilities that the Innovation Center has developed to answer the regulatory questions that come before CDER. But the approach then will be broader in the sense that it will try to use more data sources based on what we've learned in the last 5 years. And so you will hear presentations later today about what we're calling Sentinel 3.0 will be like. And as Patrizia said, we have to be mindful of funding considerations. So the Sentinel represents our commitment to protect the safety of Americans through monitoring the safety of medical products. And we will continue to have a collaborative view or a collaborative approach in Sentinel, because we at FDA certainly can't do all this ourselves. So thanks for your time today, and again, thanks for the organizers for inviting us.
Great. Thanks very much. You covered a lot of ground there, Gerald. Steve, I'd like to turn to you next.
Yeah. So I think I'd like to start with some of the major work that we're doing right now, which is really around the respiratory virus vaccines. And so, and those are sort of the big three for us, which is the respiratory syncytial virus, or RSV, influenza, and COVID-19. Just sort of focusing a bit on RSV vaccine, we identified a signal early on, earlier this year, and so we have for GBS, or Guillain-Barré syndrome. And what we've been doing is just further using the data that we have, but it takes a while to accumulate data because it's a seasonal type of situation where we're accumulating doses as we go through the season. So we've been actually presenting the data as they come up at the Advisory Committee for Immunization Practices, and that's a CDC committee. So we presented in February, again in June, and then again in October of this year. So I think the value of that is that it's starting to inform decision-making, both on how do we recommend usage in the population that the CDC is using that information for, but then how do we use it to make decisions, whether to inform patients, how to inform patients, and what information do we provide them, whether it's communications or whether it's in labeling. So very valuable. And that's just one example. So we also have work that we're doing in effectiveness. There's always concerns when this new vaccine, the vaccine has just been out, I think, over a year and a half. about the effectiveness of the vaccine and whether effectiveness will wane over time. And so we have studies going on in there, and you'll hear a bit more about that this afternoon in addition to the GBS work. We also have COVID-19 vaccines, and then for those, we've recently discovered a febrile seizures signal for that occurs in children. We're seeing it in children under 4 years of age. It's a serious condition, serious outcome, but resolves fairly quickly without any long-term consequences. But it is a scary outcome for parents. So we're working that up as a potential safety signal too. So again, and then that is going to be used for informing decision-making, whether it's, safety communications or whether it's additions to labeling with that information. I just wanted to mention Mpox has come around again. It occurred in the US in 2022. And then most recently, there's been an outbreak in the Democratic Republic of Congo. WHO has declared it sort of a public health emergency for Africa, for parts of Africa. And so we're still doing work and continue to analyze the data that we have for monkeypox vaccine. It's largely the Junios vaccine, which is a live attenuated or non-replicating vaccine. But we also have a small number of ACAM 2000 doses, which is also live and attenuated and non-replicating. And I think the important thing here is that we've been able to look at signals like myocarditis, pericarditis, and then we can look at those cases. We can't really do a firm study on on risk there, but we can look at the cases and have made determinations that largely those cases are occurring in people with prior underlying conditions that might result in myocarditis, pericarditis. So that's been very useful information too, just ensuring the safety of this vaccine. I wanted to talk just a bit about seasonal influenza because that's an important vaccine, but the other thing on the horizon right now is H5N1, and you may be hearing news reports occasionally about it occurring in cattle in the US, in certain states, and then some cases jump over to people. Most of those cases have been small in numbers in people and mild cases, and then you've heard, I think, about the most recent ones, which are in California and poultry outbreaks, and then Washington State as well. And in that situation in Washington State, there were 2 mild cases in humans. So we're watching that, and then ready to apply sort of our approach to monitoring safety should vaccination be implemented and needed in that situation. So that's sort of an emerging potential threat that we're watching. I wanted to talk about some of the other things that we're doing as far as innovative populations that we're looking at. So we're looking at special populations, and pregnant women, pregnant persons are really a focus in our work as well. So we've done a lot of work in the past on this. We continue to do that. And with the RSV vaccine, which is the Pfizer vaccine is approved for use in pregnant women, we're going to be looking at that as well to see if at certain outcomes to ensure that that vaccine is safe as well. I wanted to move on to something even more exciting for us, which is in the past 4 years, we've been focused with the pandemic on vaccines. We're going to expand that out to our other product areas, which we were covering before the pandemic. We sort of dropped those to focus on vaccines. We're now focusing now on sort of the cell and gene therapy areas, blood and blood product areas. And these really are also in the rare disease space. We've begun work on CAR T cell therapies, so I think you'll see a presentation on that this afternoon, which will be quite illuminating as to the types of challenges we face. I think the differences here between vaccines, we're talking about millions and millions of doses given, and we're looking for these very rare events. And what we're talking about for rare diseases is we're looking for small numbers of patients who have the disease, even smaller numbers who receive some of these treatments, and then even smaller numbers of people who may have adverse outcomes. So we're really looking at our databases and what databases will be appropriate to use to evaluate those products and those outcomes. I just wanted to sort of end with some of the work that we're doing with AI and machine learning as well, so artificial intelligence and machine learning. So you're going to hear a presentation this afternoon. I don't want to give too much away, but this also includes not only sort of innovative methods and approaches with AI and machine learning, it also includes new data sources because we're looking at health information exchange networks, which have important sources of data that still, I think, has a long way to go to be able to do inferential or rigorous sort of epidemiological studies, but there certainly is the hope that in the future that will be a useful tool. In addition to our claims databases, in addition to our claims-linked EHR databases and the other tools as well that we have. And with that, I'll stop there.
Thanks, Steve. You covered a lot of ground. Denitza, I'd like to turn to you to talk about some of the important updates from NEST in recent years.
Good morning, everyone, and thank you, Mark. I always enjoy coming and representing our center in the Sentinel Initiative because I strongly believe that we should be focusing on medical product surveillance system, and in fact, a lot of lessons learned from Sentinel we are trying to apply in the device space and in fact offer some of our lessons learned to the next phases of Sentinel. Medical device world is much different than the world of drugs in number of issues and which was sort of dictating the way how we approach the development of the national system. For example, devices are very diverse, ranging from eyeglasses or very simple devices that are not necessarily really being controlled by the FDA to more complicated devices, high-risk devices such as implantables or different types of CT scans or MRI machines. So as you can imagine, the way how we needed to go about this is really not necessarily to set up the system that will serve only FDA needs, but rather try to engage the ecosystem stakeholders that are on the front line of collecting this real-world data related to medical devices. First, I would say first decade in developing the vision for the national system, focus in multiple attempts to gauge where the ecosystem drivers are. So I would just give a couple of examples. Back in 2010, we launched what we call then Medical Device Epidemiology Network, which was a partnership that was geared toward establishing novel methodologies, exploring different ways of infrastructures, development, and partnerships. At that time, we primarily focused on registries, on interventional cares. Registries capture a lot of these implantable devices. And we established relationships with over 125 registries from 45 countries to actually have a better understanding what are some of these models that we can use at the time. Obviously, we wanted to expand to electronic health records, to claims data, to other data sources, and lessons learned from MD-EpiNet were instrumental in informing our center's vision for establishment of the national system, and Mark and his team were actually very much on the front line in helping us articulate that vision back in 2012. We actually launched the vision for establishment of the system in 2013. We issued the landmark report on sort of how we envisioned the steps toward development of the system. But I think what was the critical part of the moving forward was our establishment of the cooperative agreement with the Medical Device Innovation Consortium, or we call it MDIC for short. The actual establishment of that type of cooperative agreement was really what I would say was a hallmark of the way how we envision working in the future. We didn't envision running the national system from FDA, but in fact established the National Evaluation System for Health Technology Coordinating Center within MDIC. Today we have a pleasure also to have Lisa Weiss here, who actually is a director of the active surveillance system with NEST. And we are going to be also hearing later in the afternoon from Dr. Mary Beth Ritchie, who, while FDA, was one of the chief architects of the way how we envision to establish this minimum viable system for evaluation of health technologies. So let's move fast forward to where we are now. So in 2023, NEST Coordinating Center also established a subcontracting relationship with Booz Allen Hamilton as the vendor that is in charge of helping us set up the infrastructure for this minimum viable system for active surveillance. We focus today on two types of devices. One is duodenoscopes, and another one is robotic-assisted surgery that are used in the cholecystectomy. We specifically wanted to have examples of the devices that are not implantables to actually try to figure out how much we can get from electronic health systems in order to be able to identify signals and be able to move the signals, inform the FDA about signals, and then be able to do the signal management within the FDA units. So as part of, as you can imagine, now imagine the world where there is no national drug code and how you as epidemiologists and data scientists would be able to do the active surveillance. How would you actually take advantage of all these data sources without being able to identify devices? This is still the world that we live in. Often I call that world an epidemiologic nightmare because you are able to actually pull some of these data sources and to actually get based on the CPT codes or ICD codes, but it's really complicated to get the a specific device identified. So this is why we partnered with NEST, with the expertise that NEST consultants also bring to us to make sure that in the absence of UDI being embedded in those essential data sources, we are still able to pull from buckets of data that exist in the hospital systems. They are hidden somewhere in the hospital supply chain databases. They all have information about devices, but they're not in EHRs. So there are multiple things that, multiple efforts that we are currently undertaking. One is to try to figure out how we actually pull the device data from other data sources and make sure we actually get the sort of merge everything with the EHR data that exist. And there is also parallel efforts that are happening in our collaborations with the Office of the National Coordinator, in which we are trying to make the case in the USCDI version 6, next version of USCDI Core, we're going to have the field that will capture UDI, not just for implantable devices, but for all the devices. So without these efforts, obviously, it's going to be really difficult to be able to do effectively the active surveillance. At the moment, I would say that we are marching in collaboration with NEST fast forward with these activities. We currently are actively discussing with 14 partners, data partners. With some of them, contracts have been already signed. With some of them, we are actually very close to sign the contracts. With the one hospital system, we already started implementing the system, and we are getting the data to the hub, to the NEST hub on duodenoscopes and robotic-assisted surgery devices. And basically, we are leveraging the infrastructure that NEST was able to set up with multiple partners across the country that are willing to come to the table and, again, learning from Sentinel efforts, learning from previous MD EpiNet efforts to multiply our forces in this truly ecosystem-driven, patient-centric way to be able to advance the patient safety.
Great, thanks, Denita. It's great to hear about how all these programs are scaling up, maturing, and becoming more integrated into FDA regulatory activities, not to mention informing the public and healthcare providers and patients. We have a little bit of time left for questions, and I know you all laid out a lot of things that we're going to hear more about during the course of the day. But given this evolutionary nature of the program, I wonder if any of you want to comment a bit on how Sentinel is incorporating real-time lessons, continuous learning. How much is this program evolving? It seems like many of these initiatives now cover a large part of the U.S. population, not to mention people outside the country. Yeah, Steve?
Yeah, so, we are evolving as far as methods, and I will say during the pandemic when we were monitoring our vaccines, we were using sort of sequential methods, max SPRT and the like, and And the challenge with those is that we were seeing a fair number of false positives for potential safety signals. And so we looked at ways in the next year, well, probably 2 years ago would have been, to really decrease, the number of false positives that we would see. So we introduced sort of a screening method for self-controlled case series type analyses, along with descriptive analyses, so we could get more robust data out of more robust results, better controlled results, and then fewer false positives. And so I think we've managed to virtually reduce the number of false positives by probably 80% or so. The one thing is that we've also increased efficiencies as well, because instead of looking on a monthly basis over a period of 6 to 12 months, we're only looking twice. And so I think one of the disadvantages, though, I will say, is that it takes longer to get the results for those studies. So this year we've gone to just trying to get more rapid results early on, and then using observed versus expected, concurrent comparators, and a variety of Bayesian methods. And then on the back end of that, we have the self-controlled. So we still get kind of the best of both worlds, where we have the self-controlled results, but we have some earlier results where we can use that to make decisions. And I'll stop there.
Great. Thank you. Gerald?
Right. So my remarks focused on a lot of particular drug adverse event reactions that we've been looking at, but we also have started using Sentinel for signaling. It's still in more of a pilot phase now, because we have to figure out methods to do this without a lot of false positives across the wide number of drugs that we have. So that's work in progress. And then we're also continuing our work on enhancing our use of mother-infant linkages to look at safety outcomes in pregnancy. So.
Denise, anything you'd like to add here?
I would just like to add that CDRH's experience in registries over the course of the 15 years potentially might be useful as the colleagues from CEDAR are looking into development, and CBER for that matter, working on expanding the data sources sort of portfolio. What's working, what's not working, so there are registries and there are registries. So one can actually potentially take advantage of our work with professional societies, registries, and patient-led registries to actually expand the Sentinel work in that space.
Great. So thank you all for those comments. The program is continuing to evolve. So it's 2024, can't get through a Sentinel session or anything else without asking a question about artificial intelligence. Steve, you mentioned in your comments that it's helping with some of the incorporation of the health insurance exchange data. I imagine that's kind of diverse and can see some applications there. And we'll talk more about that later today too. But for things that people may not hear as much about later today, anything that you all would like to add? Denise, I know you all have been working in this area.
So yes, among other exciting program that we at CDRH actually have is the digital health sort of oversight, and in fact we house at CDRH the Digital Health Center for Excellence, which is the center for excellence that actually work with all medical product centers within the FDA. So artificial intelligence and the softwares that we're using, and obviously that is a huge portfolio within digital health program. In fact, we approved almost 1,000 AI-enabled devices thus far. And as you can imagine, that is very dynamic field. Things are moving very fast, and our review process needed to adjust to this type of changing environment. We don't want to be an obstacle for the approval. At the same time, we want to make sure that there is a responsibility beyond approval in the total product life cycle fashion to be able to continue to monitor how those products are performing in the post-market setting. So as there is actually very informative website that Digital Health Center for Excellence has, and I really would recommend that we go and see all the activities that are happening in this space. For example, we also have upcoming toward the end of November, there is going to be an advisory committee meeting on the generative AI throughout the entire total product life cycle, in which we're going to be seeking input from experts in all sectors of the society of what are some of the gaps, how review process can be improved. I believe that we will be collaborating even more in the future with colleagues from CEDAR and CBER, because as I said, we have a regulatory jurisdiction of AI products, but they are applied throughout the entire spectrum of medical products.
And so we also recognized that AI was going to be important for this. That was part of our 2019 strategic plan. So that you'll hear a lot about today from the Sentinel Innovation Center. But we have been using AI in other aspects of our work that aren't under the Sentinel umbrella. And our FAIRS database, our adverse event reporting system database, has something around 28 million reports in it. We get about 2.2, 2.3 million reports a year. And a lot of them are duplicates. And for our safety evaluators to prepare a case series, they have to traditionally have gone through a fairly manual process, a time-consuming process of identifying and adjudicating duplicates. So our staff has worked on something called InfoVIP, and I forget what the acronym stands for, Visualization Information Platform or something, that uses AI to sift through these reports and identify potential duplicates, present them on a screen to the safety staff, and the safety staff can then just go in and say, yes, this is duplicate, this is not. They put a check mark there, and then that is preserved in the database. So we see AI as a way to really improve efficiency when sifting through these large volumes of data. And that's been very helpful for us. We've also used these systems to take safety reports and make temporal charts of events that happen within the narrative.
So lots going on, and I know we've only got a minute or two left, but it just as a final, maybe not fair as a brief comment, but it's been really interesting to see Sentinel evolve from sort of limited data sets, claims, some registries, et cetera, to much more systematic, from trying to follow up on questions or safety signals that are identified elsewhere to finding them here, to having even much more active programs of working on effectiveness as well as safety. You're integrating a large amount of data from an increasingly diverse set of data sets. What are the big challenges that you're working on overcoming right now? Any that you'd like to?
I'll just reemphasize. I mean, as we move into the rare disease space, I think there's just the huge challenges with the small numbers. And I think, the combination, I think registries is an important part of that. And so I think we've got to really start merging those in. I mean, we do use registries in vaccines for the immunization information systems, and that's been really successful. So I think we've got to leverage registries for the rare disease space as well, and that will really help us, I think, in identifying events.
Thanks.
Right. And I think that as we get more and more data, as we incorporate AI and more granular data from the EHR, we're never going to have all the data neatly packed the way you do in a clinical trial. But can we develop the analytical approaches, I think, which you'll hear about today later as well, to maybe overcome some of those challenges?
I would also add that data curation, quality of the data is really very important, especially in the device space, when we cannot completely rely on what had been mapped in the, let's say, OMAP and other sort of ways of making the data sets more analytical, right, in nature. So in the device space, we have to be thinking about novel ways to data curation, continue to actually invest efforts in collaboration with the Office of National Coordinator on interoperability efforts to promote the flow of data across different data sources, things that we can actually combine using EHRs, claims data, registries, patient-generated health data, and those sorts of things. So in the future, I really envision that our efforts to establish the nest and Sentinel will converge, and there will be larger context and setting in which Sentinel can provide umbrella providing a lot of input into more granular data that we need for the device space.
Really interesting. And the pathway, it sounds like, through US CDI and interoperable electronic data to get the unique device identifier in there too. All right. I want to thank all of our panelists for this excellent discussion to kick off today's meeting, describe some of the things that have happened, some of the things that are going to happen, many of the things that you're going to hear about later. Thank you all for joining us this morning. And thanks for all the hard work on this program. We're now going to turn to our next session on regulatory applications of real-world data, highlights from the Sentinel system. And for that, I'd like to introduce Patrizia Cavazzoni, who's Assistant Research Director at Duke-Margolis, who will be moderating this session. Thanks, Victoria.
Good morning, everyone. My name is Victoria Jem. Thank you, Mark, for the introduction. And I'm an assistant research director at Duke-Margolis. So I have the pleasure of moderating this session, once again entitled Regulatory Applications of Real-World Data, Highlights from the Sentinel System. So before we begin with some really wonderful presentations, I'd like to turn it over first to Dr. Jamal Jones, a member of the Sentinel core team, to start us off with some brief introductory remarks. So Jamal, if you'd like to come up.
Good morning. I'm Dr. Jamal Jones, an epidemiologist on the Sentinel core team, and I have the distinguished honor to introduce our speakers and moderator for the regulatory applications of real-world data highlights from the Sentinel system session. Our panel for this session includes Dr. Sebastian Schneeweiss, the principal investigator of the Sentinel Innovation Center, a professor of medicine and epidemiology at Harvard Medical School, and chief of the Division of Pharmacoepidemiology and the Department of Medicine at Brigham and Women's Hospital. He co-leads the RCT Duplicate Initiative to understand when and how real-world evidence studies can reach causal conclusions. His research focuses on the comparative effectiveness and safety of biopharmaceuticals. He has developed analytic methods to improve the scientific validity of epidemiologic analyses using complex longitudinal healthcare databases for newly marketed medical products. The overarching theme of his research is applying advanced real-world data analytics for regulatory decision-making transparently and in rapid cycles. His work is published in over 500 articles and is funded by the National Institutes of Health, Patient-Centered Outcomes Research Institute, IMI, and FDA, where he is also a voting consultant. Dr. Schneeweiss is director of the Harvard Brigham Drug Safety Research Center, funded by FDA and CEDAR, and methods lead of the FDA's Sentinel program. He is past president of the International Society for Pharmacoepidemiology and is a fellow of the American College of Epidemiology, the American College of Clinical Pharmacology, and the International Society for Pharmacoepidemiology. Dr. Rishi Desai is the operations lead of the Sentinel Innovation Center, an associate professor of medicine at Harvard Medical School and Brigham and Women's Hospital, and an associate professor of epidemiology in the Department of Epidemiology at Harvard T.H. Chan School of Public Health. His research focuses on generating high-quality evidence from comparative safety and effectiveness of drug treatments for chronic diseases, especially in populations typically underrepresented in clinical trials, including pregnant women, the elderly, patients with multiple chronic conditions. His research projects have mainly concentrated on rheumatology and cardiology, where he has extensively used observational study designs as well as systematic reviews to answer clinically important research questions related to drug effects on a variety of health outcomes. He also has a special interest in applied methodological research aimed at improving confounding control in observational studies. And Dr. Darren Tull, the principal investigator of the Sentinel Operations Center, endowed professor in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. He is a pharmacoepidemiologist with an interest in comparative safety and effectiveness research of medical products. His research focuses on assessing the risks and benefits of medical products using real-world data collected as part of routine healthcare delivery and developing and applying privacy-protecting analytic methods to conduct multi-center studies and distributed data networks. Dr. Toe is also principal investigator of projects funded by the National Institutes of Health, the Agency for Healthcare Research and Quality, the Patient-Centered Outcomes Research Institute, and FDA. He is a fellow of the International Society for Pharmacoepidemiology. And finally, this event will be moderated by Victoria Jim, an assistant research director for the biomedical innovation team at Duke-Margolis Institute for Health Policy. She works with the Medical Products Development and Regulations team, specifically leading the Institute's FDA PDUFA cooperative agreement work. Over her time at Duke-Margolis, Victoria has worked on projects spanning a range of topics, including rare disease drug development, prescription drug promotion regulation, development and regulation of psychedelics for therapeutic use, hepatitis C elimination, and value-based payment approaches for medical products, among other topics. Dr. Schneeweiss and Desai will first present on the many achievements that the Innovation Center has had in the past 4 years, and Dr. Toe will present on the studies conducted using the Sentinel System and the contributions of Sentinel to address important safety questions. Please welcome our moderator, Victoria Jim, and esteemed panel for this session. Thank you.
Great. Thank you so much, Jamal, for providing those wonderful introductions for all of our esteemed panelists for this session. So with that, I would like to just first note that while the session is focused on 2 content-rich presentations, we will have a few minutes, just a few, for Q&A towards the end of the session. So we encourage you, if you do have questions, to please submit them in the Slido throughout the session, and we'll incorporate as many as we can during the brief Q&A at the end. So with that, we'll now turn to our first presentation for this session. So I'd like to welcome Sebastian and Rishi up to join us.
Okay, great. Thank you for the introduction and the opportunity to present some of our work. And I will be briefly mentioning some of the data infrastructure that we have built, and then Sebastian will follow up with many use cases that we have implemented using the data sources. Next slide, please. Next slide. Is there a clicker? Sorry.
There is no clicker. All right, just...
Okay. So this is just a standard disclaimer slide. Next slide, please. And this is a list of our partners that we work with. Next slide. So as I mentioned, I will briefly be describing the real-world evidence data enterprise, which is the data infrastructure that we have built, and then Sebastian will follow up with some use cases from year 5 demonstration projects. Thank you. Now I do have the clicker. All right. So without further ado, let's dive into what the real-world data enterprise is all about and why it's needed. So a few years ago, the team led by Dr. Judy Morrow conducted a large review of the analysis that were completed in the first 5-year cycle of the Sentinel system. And this review found that while Sentinel was largely successful in addressing many pressing questions regarding public health, but about 60% of the time it fell short on some questions that the FDA was interested in for various reasons. And a root cause analysis was conducted, which found that in most or many of the cases, the reason why the FDA Sentinel system was deemed insufficient was that it did not have the clinical granularity in the information that was needed to address the question. And so that's the reason why the FDA tasked the Sentinel Innovation Center to come up with this system of at least 10 million or more lives to be able to leverage more clinically rich information from the EHR system that is linked to claims data to preserve some of the unique strengths that the claims data have to provide, which mainly has to do with longitudinality of the information. So today we will be describing the network that we have built and some of the capabilities. So there is a fair bit going on in this slide, so I will briefly explain what all the boxes mean here. So you can start from the two boxes on the side where we have the two prongs of the real-world evidence data enterprise. So on the left, you have the commercial network, which has data from 21 million linked lives from Health Verity and Triantex, two of our commercial data partners. And then on the right-hand side, you have data from 4 academic sites, which includes Marshall Brigham, Duke, Vanderbilt, and Kaiser Permanente in Washington. So the reason why we developed this system in these two prongs is that on the left side, you have the commercial data providers, which has the advantage of the volume. So they can bring in large number of lives, but the challenges with respect to data access, the direct access to granular data that is needed, it remains challenging because they cannot allow Sentinel investigators to touch the raw data when it comes to privacy sensitive information like free text notes. And so to be able to do the methodological development, you have to have access to data, which is what the development network provides, because as institutional investigators, we have unrestricted access pretty much to these data, which allow us to build new algorithms, build out new tools that we can then apply to the commercial data. So that's what the center box is about, which is this analytic hub. So the methods and tools that we develop at these commercial sites, we use on these commercial sites on the 21 million lives to conduct various investigations. And this system is ready to use. So FDA, we envision that FDA will query the system directly using the analytic hub, providing their questions, and then using the data infrastructure as well as the analytic capabilities that we have developed, we will be able to rapidly implement some of these analyses. So this is just a summary of various studies that are papers that we have published to describe the system, and I'll let you quickly glance through this for your future review. And so that brings me to the purpose of the presentation today, which is to provide some initial results for year 5 demonstration projects that have been conducted using the real-world evidence data enterprise. The goal really is to show how we have been able to implement these studies, not really interpret the clinical results as much, but to be able to show that we are, as a methodological demonstration projects, that we were able to complete many of these studies in rapid cycles and using innovative methods. And so Sebastian will talk about these the framework of 1+5 use cases. And the focus really is on implementation flexibility, practical issues, and efficiency. So this is the last slide that I will cover, which really is not meant to be read. It's probably too small, but just to show that the 20+ methodological development project that we have as the Innovation Center undertook over the first 5 years. And then the last year is where the use case projects that Sebastian will talk about today, where we are integrating the learnings and the tools and analytics that we have developed so far. And so with that, I will turn it over to Sebastian to talk about some of the use cases.
Great. If it's okay for the camera, I would actually love to stay seated because then I can actually see what I'm talking about. Is that all right? All right, thank you, great. So, right, as Rishi said already, so last year was really busy, culminating the 4 years of prep work, building things, demonstrating now what we can do with the new system that we have set up. And the one key use case that I'm going to talk about is implementing a protocol-based analysis, a full study in the new data asset where we have claims data for data continuity, as well as EHR data for data granularity, for enhanced data granularity, as well as 5 use cases that strengthen analyses that were done in the claims data analysis. And I will go quite rapidly through these results. The slides will be shared in a few days with you, then you can read up all the small print, so I really urge you to focus more on the bigger picture issues that we are raising here. Once you have a data infrastructure of about 20 million plus lives, where you have claims and EHR with some overlap, with some meaningful overlap in person time between those two data sources, you can do studies in conditions that are reasonably prevalent or exposures that are more frequent if the prevalence of the condition is low and the incidence of use of the medication of interest is low, then even 20 million lives might be too small to do adequately powered analyses. The numbers of events are going down rapidly, right? So just this is a precursor for this. So the first use case I want to talk about was actually led by Dr. Desai, implementing a protocol-based analysis of understanding the risk of acute pancreatitis in patients treated with SGLT2 inhibitors or DPP4 inhibitors with type 2 diabetes. It was thought that in claims data, we're doing an incomplete job in identifying acute pancreatitis. Hence, we wanted to have the EHR data available. And we were also concerned about inadequate confounding control if you don't have full measurements of alcohol use, smoking, and BMI. On the right side, at the upper table, you see the findings in a federated analysis between the two commercial data assets that Rishi just described, Health-Verity and Trinetics. You see on the very right column per protocol follow-up analyses an incidence rate of 2.4 per thousand acute pancreatitis in the SGLT2 group and 2.7 in the DPP4 inhibitor group. And you do have similar numbers in the Trinetics, and you pool those incidence rates after full adjustment together, and you get an overall in the very right lower corner, an overall estimate of the relative risk of 0.84, so a 16% reduction of acute pancreatitis, if anything, with some uncertainty around it. Right? We're working with 20 million lives altogether. We are working with 33,000 and 51,000 person years in one of those databases. Nevertheless, we still have quite some uncertainty around it. Still, it makes us come to the conclusion that it's unlikely that there's an increase in the risk of acute pancreatitis among SGLT2 inhibitors based on this enhanced analysis where we have now both claims data as well as EHR data used for this full analysis. The focus on this table here, we kept track how much time it took us because year 5 was also very much about efficiency. How fast are we in turning this around? And you see that the data refresh took us about 60 to 90 days. The data refresh in a routine application works in the background, is not really attributable to the specific study. 90 to 120 days agreeing on the study parameters. There's lots of back and forth with FDA scientists to agree on what do we really want to study and how do we want to study that. The analysis itself was quite rapid within 30 days because we use the existing common data model and we used the existing analytic tools. The reporting, again, was quite rapid, but also the interpretation, again, together with our colleagues from the FDA, takes some time. Overall, particularly if you discount the data refreshes, this is a fairly rapid turnaround that is now enabled in this new real-world evidence data enterprise structure. We have now, with regard to ARIA, implemented this the technical feasibility of an FDA protocol-based analysis in this dual data source. The size is still a limitation for some of the use cases, as I illustrated. Let's dive into the other 5 use cases where the main analysis is done in claims data only, but we supplement that with a subset of data where we have electronic health records available in order to understand the validity of the analysis and enhance the validity of the analysis. And what you see in all these slides on the right upper corner, you see the use case. This is the orange use case, the first use case, which is about rapid balance evaluation of characteristics that are unmeasured in the claims, but observable in the electronic health record database. So the area need is here that the concern is in claims-only analysis, we have residual confounding by factors that are not observed in claims data. The specific example here is comparing ACE-ARB use against ARNI use in Entresto in patients with heart failure. The outcome is angioedema, a serious adverse event. The concern is that claims will incompletely capture smoking, BMI, and history of allergic reactions. Now, what you see on the right side, in the lower half, let's start in the lower half of this figure, you see what we thought are important confounders that need to be adjusted as measured in the claims data. And the red dots are before any adjustment, and the blue dots are with fine stratification by the propensity score. And you see that the blue dots are all moving towards the left. And they're all left of this vertical line at 0.1. which is where we want points to be to conclude that there is, it's highly unlikely there's meaningful residual confounding by these factors, right? And then we go to the upper half, characteristics that were not observable in the claims data, but observable in the EHR, like HbA1c, CRP, alcohol use, smoking, BMI, as well as black race. Black race is assessed in the EHR as well as in the claims data, and both data sources claim this is self-reported. Nevertheless, we see quite some discrepancy in these two different data sources. But what you see in the upper half, and that's the key point here, is that the little triangles, the red triangles, all move very much to the left as they become blue triangles, and most of them are now also left of the vertical line, which means by adjusting just in claims data, what we observe in claims data, we have also achieved balance in characteristics that were only observable in EHR data. That's the interpretation of this slide, and it can be quite useful in understanding and solidifying the validity of claims-only analyses. Here is another example where we push a little further the application. The example here is understanding the two smoking cessation medications and whether they are related to adverse neuropsychiatric events. The unmeasured confounder of interest here is the history of suicidal ideation, suicidal action. Suicidal ideation is almost impossible to assess in claims data. We were hoping we can do a better job with EHR data. We used our NLP toolbox, and you see in the upper table there that we identified suicidal ideation 10.5% in one group and 6.6% in the other group based on NLP analysis of the free text notes. Now, let's push this a little bit further and assess through simulation analysis in a very canned software product, what is the impact of this residual imbalance that we see. And you see this, the pink box plot there, you see an unadjusted analysis where we see a 10% decrease in the risk of neuropsychiatric events. By claims only balancing, only claims data, this point estimate moves dramatically to the null effect of 1.0, which is 0.998 or something like that. And this point estimate is further moving to the null, just a tiny bit, when we have this added information from electronic health records for confounding adjustment available to us. And you can make an assessment, is it worth it or not? But at least we have a quantification now of the potential residual confounding and how we could fix this. The time that is needed for this is, again, protocol development and agreeing what is really the study question takes some time, 4 to 5 weeks. Running these data extractions was actually quite rapid, as you can see here in this table. So we are quite happy with the efficiency of the process in order to satisfy FDA needs to respond to ARIA requests. So the FDA now has an expeditiously assessment available to assess the balance of unmeasured confounders, unmeasured in claims data, but observable in EHR data sources. Now let's push this even further. Now we have seen an imbalance, and residual imbalance. Can we correct our estimate that we have from a much larger claims data asset? The use case here is thromboembolic events in patients with COVID versus patients with influenza. So there's no treatment evaluation ongoing. This is really just comparing two conditions and the risk of thromboembolic events. BMI is considered an important unmeasured confounder. And what you see in the upper table there is illustration of the BMI measurements. And this was done in the Kaiser Washington partner site. Quite some imbalance. If you look at the 35 plus BMI, it's 28% in the COVID patients, but it's 19% in influenza patients. So there is a difference there in the BMI distribution between those two in patients with those two conditions. And what you see in the lower table is, if you focus on the lower half of the lower table, the claims-only analysis, the relationship between COVID, having COVID and the incidence of thromboembolic events is 35% higher than in patients with influenza. And that is not adjusting for BMI. Once we adjust for BMI and correct for the missingness of BMI, we see this 1.45, so a slightly higher risk. And again, all of these use cases you're describing to you, they're not rocket science. The science, the epidemiology is well understood of these things. It's about the efficiency of the process and the data source. And again, we show you here now the numbers of days that it took us Again, 4 to 5 weeks to agree on the protocol and exact study question. But then from there on, it's really just days to implement these analyses and use the standard software product in order to correct our estimate for the residual confounding that we see in the subset of patients where we have electronic health records available. And that is meant to be a part of the routine toolbox for ARIA inquiries. Use case number 3 now is the use of natural language processing to have a better assessment of study endpoints. Here it's the use of natural language processing in supporting medical record review. We still consider as the gold standard the medical record and the review by an expert physician. Supporting that review, to expedite the review, we have developed a review tool that is supported by NLP to enable the physician to review these sometimes massive records. Hundreds of notes sometimes for these very sick patients to go through this much faster. And here you see this use case here where subjects were identified in the claims, then the EHR records were pulled for a certain interval. It was further zoomed into a much tighter interval before then actually a few charts were reviewed. Key to this whole thing is, again, efficiency and speed in connecting to the gold standard information, the EHR information, and reviewing such information. And what you see is about 14 days for any of those 4 activities, deriving the protocol, being clear of what we want to validate here, the retrieval of the notes, about 15 days, the actual review by the expert, another 15 days, and the reporting 15 days. We are quite happy with the 60 days overall with regard to this expert review, which takes way longer if you have ever been involved in actually paper-based record review in the good old days. We were sometimes talking about a year of doing this, right? So it's an enormous improvement in speed. Use case number 4, expanding claims-based analysis with deep clinical information. Here, the example that we used here is a missing exposure, a missing covariate, that is cannabis and cannabinoid product exposure that is not really, wouldn't expect this to be popping up in claims data. It is not a reimbursable medication in most cases, and we assumed it's underreported. And then trawling through the structured and unstructured information in electronic health records with our partner site at the Vanderbilt, Josh Smith was in the lead of that, identified 45,000 subjects who had evidence in the notes of CCP. And when we looked at the claims data for the same patients, only a third of those were identified in claims data. So you see the huge opportunity to identify exposures that are not really popping up in claims data. The easy extrapolations also over-the-counter medication use, aspirin and things like that. That is another use case similar to this use case here. All right? In the same spirit of using deep learning and natural language processing, we had a project led by Sasha Dublin, by our partner site at Kaiser Washington, to identify health outcomes of interest where we think that claims data might be insufficient. And it came up with a list of 9 priority conditions and worked through 7 of those already in identifying how well will we be doing in identifying these endpoints when we have EHR information available, and what is the algorithm to identify those endpoints with EHR data. So we are ready to go once an ARIA use case comes down the pipeline so that we can jump on this and in an expeditious way have the best algorithm possible available to us. Overall, what you can see is that we now have a fit-for-purpose assessed phenotyping pipeline developed to use free text notes with the claims in addition to the free text notes available. Develop transportable algorithms. We have, for good reasons, the development network that Rishi described with the 4 academic partners. There we can test transportability of the algorithm. We might develop them at Kaiser. We move them over to MGB at Boston and see how the performance is in this other healthcare system with different medical practice styles, with different recording practices, and so on. These are all things that need to be considered when you work with electronic health records and certainly with free text notes. Use case number 5 is slightly different. This is about, Dr. Delpen mentioned this already, about signal detection methodologies, and tree scan approaches are quite frequently used now and fairly standard in claims data, but we wanted to expand this to free text nodes, and we abstracted free text nodes, automatically turned them into measure nodes, measure items, and put them into a hierarchy according to measure, and use that hierarchy to run the tree scan algorithms to identify hypothesis-free identification of any signals. The example study here is comparing sulfonylureas versus DPP-4 inhibitors, both medications, second line for type 2 diabetes. This is all about after propensity score matching to balance those two groups. We used structured EHR information as well as unstructured information that is pre-processed by NLP, as I had described. So on the right side, you see the results of that, and what you see is what pops up as a signal. This is slightly underpowered, I should mention. This is only done in one of the sites, only at MGB. We are currently rolling this out to other sites. What pops up is headaches, which is a very non-specific symptom for hypoglycemic events. So it kind of fits what we expected, but several other things want to pop up, but they're not quite reaching the threshold. Tremor, and very down here is hypoglycemia. This is the thing because this is underpowered simply. What I really want to point out is in the two green columns here, you see under billing code data, how few data points we have to identify those symptoms. You see seven times mentioning of headaches, right? Well, if you go on the right side, when you use the free text notes, we see many more. Now it's in double digits. We have 66 mentioning of headaches, right? So that is increasing the opportunity to identify signals that are largely based on symptoms rather than hard diagnoses. So it's a huge opportunity here of this expanded capability now that we can roll out in this new EHR claims linked infrastructure. Another side project is the exploration that was also mentioned here of the utility of health information exchanges as a data asset, as a truly what I call patient-centric information rather than insurance-centric or provider-centric information, what we usually work with when we work with secondary data. It's actually patient-centric. Everything moves together in these health information exchanges. In this little Venn diagram, you see the messiness of the overlap of multiple payers and multiple EHR serving one patient. We worked here together with Anjem Khurshid and Rishi Desai, the PIs, with the Health Information Exchange in Oklahoma, serving about 4 million patients in Oklahoma. What was surprising to me is the size of the cohort that we could immediately identify in this health information exchange. 76,000 subjects with DPP-4 inhibitor use and 100,000 with SGLT2 inhibitor use, right? So now we are talking pharmacoepi study size. And what you see is the completeness of data, HbA1c, creatinine, about half, about 2/3, reported and available in a fairly tight time window, as well as ejection fraction as expected in patients with heart failure, BMI recording. Quite a positive experience in thinking about expanding a patient-centric secondary data source scalable to the entire United States. I think that's something that we should pay attention to and probably further evaluate and know that some of the other activities are using these data already. So I'm quite upbeat on this development and look forward to further expand that. Let me summarize this. And again, all the details are available in the slides that you will be getting in a few days. We have now established the real-world evidence data infrastructure to serve the future ARIA requests. It offers visibility into additional clinical information not available in claims. It can improve the validity of studies of medical products and clinical practice, and we have demonstrated this in the year 5 projects. It addresses some ARIA insufficiencies related to availability and measurement of certain study variables. If you remember the cannabis use, for example, that you have now a data source available that captures these things that are clearly not available in claims data. We have developed tools for rapid free text queries, NLP tools, and metadata generated in order to efficiently query these very large node databases We think that real-world evidence, the real-world evidence data enterprise is now ready for use and for further growth. We are ready for growth. And the integration of the real-world evidence data enterprise into the FDA ARIA sufficiency determinations is under development with our colleagues from the FDA. So that was my whirlwind tour through all the year five projects and the results, and happy to take any questions after my other speaker is presenting.
All right, great. Thank you so much, Sebastian and Rishi, for such a wonderful, again, content-rich presentation. We'll now turn to Darren. I'd like to welcome you to the stage for your presentation.
Oh, and thank you to all the people that contributed. Sorry about that. But truly, the dedication to Sentinel and to the public health of America is really remarkable of these individuals who contributed to this.
Agree completely. So here are my disclaimers. I would like to acknowledge the collaborating institutions of the Sentinel Operations Center. So this is what I hope we could talk about today. I will give this group a progress report of the activities that we did at the Operations Center last year. So I'll talk about the regulatory highlights and talk a little bit about the signal identification activities that we did last year in Sentinel, and spend some time talking about our work with cannabis use, and end with just a very brief review of the data and tool expansion activities that we completed last year at the Operations Center. So regulatory highlights. So I'll give you some measures of our productivity last year, and then I will dive deeper into a number of projects just to give you some idea about the work that we support within the Operations Center. So these are the numbers from the last fiscal year, which started from October of 2023 and ended in September of this year. So as Dr. Delpin mentioned, we completed 82 analyses or queries last year. So there are a number of ways to populate this measure. So the way that we set it up is by counting the number of packages that we send to our data partners. As Sebastian mentioned, these things are more predictable. It takes as long as we need to agree on the specification and things like that. But once those are done, we can count the number of packages more easily than the upstream of activities. So there were about 49 descriptive analysis that we completed using the Sentinel distributed database last year. We completed 12 inferential or comparative analysis. We also did 6 signal identification activities. I will say that this is probably an underestimation of the activity of the analysis that we completed, because a package might include multiple medical products or multiple product outcome pairs, and they often have multiple analytic scenarios. So a package could be a big study or just a simple query, but this is just how we classify it. At a given time last year, we supported more than 20 queries simultaneously. Some of these might be a multi-year activity. Some will have a more rapid turnaround, like a few weeks. But this is the way that we set it up. So at a given time, we have people and resources to support up to 23 queries simultaneously. If you look at the numbers on the right-hand side, we posted 82 reports and 20 analytic packages on the Sentinel website. We supported 19 manuscripts in peer-reviewed journals and over 40 posters or podium presentations at scientific meetings. If you look at the entire 5 years of the current contract, you can see that the number looks okay. So we completed just under 400 analyses. And there were 228 descriptive analyses. more than 50 inferential or comparative analysis and 13 signal identification analysis. We also did work with our additional EHR data sources that I will talk a little bit about later. So we supported just under 100 analysis with these additional EHR data sources. So this analysis sort of supported a range of regulatory activities. So the work that Sentinel did might be included in the advisory committee meetings, either the briefing documents or actual presentations. We might be helping FDA with potential label change or drug safety communication. You will see that there's more descriptive analysis than other types of analysis. Some of these descriptive analysis would be part of a larger project that would involve an inferential analysis. Some would be to provide more context to other data that FDA has access to, for example, data from spontaneous reports. If you look at the right-hand side, these boxes, so overall, in the last 5 years, we supported 346 new safety concerns, which was a substantial increase from the time we started tracking this number more systematically. We shared 57 analytic packages. We supported 24 sponsor notification letters. There were about 300 work products, such as presentations, manuscripts that you can find on the Sentinel website. There are 67 statements of study impact and close to 300 reports that are freely available on the Sentinel website. So these are the 11 products that I will highlight here. So there's a section within the Federal Food, Drug, and Cosmetic Act, the Section 5050, which says that if there is some safety issue that FDA wanted to follow up on in the post-market phase and during the peri-approval period when they are thinking about how to actually monitor the safety of these products, FDA could issue what we call a post-market requirement study. But if the Sentinel Active Risk Identification and Analysis System, or ARIA, was deemed sufficient to monitor the safety of these products, then FDA would just monitor the safety within the Sentinel instead of issuing a PMR. So there are 11 of these products that fall under these categories. They are at different stages of monitoring. And as you can see, 3 of them have been completed. And I'm going to talk about one of them later in the session. And the others are at the different stages of monitoring. So the way that we set it up is that Sentinel will monitor the uptake of these products on a regular basis. If the uptake reaches a certain pre-specified threshold, then we will launch a one-time comparative analysis to look at the safety of this product and a pre-specified list of outcomes of interest. So that's why many of them are still at the monitoring phases. And these projects usually take a few years to complete. Some are shorter, some are longer. And here's a list of 5 products that I'm highlighting here. So these are products for which a post-market requirement study was not considered during the peri-approval period, but FDA still wanted to look at the safety of this medication in the post-market phase. And ARIA was considered sufficient to monitor these products. So that's why we are also doing that for FDA, even though a PMR was not considered during the peri-approval period. As you can see, most of them are still at the monitoring phase. So now I will talk about 6 projects just to give you some flavors of the work that we supported. And I'm going to continue the trend of having busy slides because the slide deck will be available and this session will be recorded. So we err on the side of providing you with more information than less. But I will talk about what I can for the time that I have. So this first analysis was looking at the risk of serious infections following use of ustekinumab, which was initially approved in 2016 for Crohn's disease. So this was actually one of the first queries for which ARIA was considered sufficient and a PMR was quote-unquote avoided. So it has this significance in terms of how ARIA is set up to do. So for this, we looked at the risk of serious infections with ustekinumab compared with other drugs that are used for Crohn's disease, including adalimumab, infliximab, and vedolizumab. So we used a previously validated algorithm to look at hospitalization for serious infections, which actually is a collection of 7 individual infections. And during the monitoring period, of course, we experienced a COVID-19 pandemic, so we added COVID-19 as another infection that we looked at. So we used inverse probability of treatment weighting to adjust for baseline confounding, and we also did a propensity score match analysis. So here are the results. Again, a busy slide, but I will draw your attention to the left-hand side of the screen. So we identified more than 15,000 ustekinumab new users and more than 50,000 new users of the comparator drugs. We achieved pretty good balance on the baseline characteristics after weighting. Even though I did not show you the tables here, the links at the bottom would take you to the reports. The forest plot show you the hazard ratio of different analyses. The one that I'm highlighting here is the overall analysis, which show that there was no evidence to suggest that the risk of serious infection was greater in ustekinumab user compared to what we saw in the comparator users. So the second analysis was something that Dr. Delpan mentioned earlier. So this was looking at incidence of interstitial lung disease among users of vedolizumab or natalizumab. So the background was that through the periodic safety reports, there was some concern that there could be an association between interstitial lung disease and vedolizumab use. And actually, the European Medicines Agency updated what they call the summary of product characteristics to include this information. So FDA asked Sentinel to look at the incidence rate of interstitial lung disease among people with inflammatory bowel disease and were treated with either vedolizumab or natalizumab. So the results are shown here. So this is a descriptive analysis just looking at the incidence rate by medical product. What I will highlight here is that earlier this year, FDA actually approved a label update to include interstitial lung disease into the post-market experience of the prescribing information, because based on the spontaneous report system data, there was some indication that it could be an association. The Sentinel results sort of help FDA contextualize the information from the FAIR system, because one nice thing about Sentinel is that we get the denominator information. So we are able to estimate the incidence or incidence rate of the outcomes of interest by product. So I think this is the third analysis. So this is looking at the safety of medication during pregnancy. So at the moment, Sentinel has data on close to 12 million deliveries with mom and baby link records. So it's a huge data resource. So this was looking at the use of amlodipine or modafinil during pregnancy and the risk of non-cardiac malformation in the infants. So we had previously completed an analysis looking at the association between these drugs and cardiac malformation, and we did not find an increased risk. So this was a follow-up analysis looking at amlodipine and modafinil in comparison with methylphenidate or amphetamine or no use of this drug during the first trimester. We used one-to-one propensity score matching to adjust for confounding. The results on the right-hand side are shown by age group and by comparator drug. Overall, there was no suggestion that the risk of non-cardiac malformation was greater in amlodipine or modafinil pregnancy in the first trimester. This analysis was looking at pediatric and adult utilization of injectable methotrexate products. So for this, we did 2 parallel analyses. One was within the rapid Sentinel distributed database, which was predominantly claims data, and the other was within our EHR data source. So the background was that in March 2023, FDA declared a shortage of these injectable products, and the agency was asked to investigate the impact of this shortage in response to a public inquiry. So we did this analysis, and we did it separately within the adult population and pediatric population. And for these results I'm showing you here, we also stratified by evidence of cancer because methotrexate was approved for multiple indications. So if you look at the result on the lower left-hand side, you see that the utilization remained pretty stable among the pediatric population who had evidence of cancer. But we did see a drop of utilization among adult population with evidence of cancer. So on the right-hand side, these are individuals without evidence of cancer, and we saw utilization to be relatively stable among the pediatric population, although there was some indication that there was some reduction after the shortage was declared. You see a much more obvious and dramatic drops in the adult population. So we did a parallel analysis within our EHR data source through the Trinetics collaboration. So I did not break it down by evidence of cancer here, but the overall findings were more or less consistent with what we just observed, which was that after the shortage was declared, there was indication that the utilization dropped. This was true for both the adult and pediatric population, although the changes were not as dramatic as what we saw from the claims-based analysis. This is another descriptive analysis looking at utilization of Schedule II stimulant medications. So the use of these medications in adult has increased pretty dramatically since 2000, and there was evidence to suggest that it sort of picked up during the COVID-19 pandemic. So FDA asked us to do some descriptive analysis to help with a potential future inferential analysis. The goal was to identify individuals who might be at a higher risk of adverse events. So doing this analysis allowed us to better understand the utilization and the patient characteristics. And we did this before pandemic and during pandemic. So here are the results. So there was some variation in terms of cumulative use by age group. Among those who are 65 or older, the median use was about 90 plus days. And we observed a highest median use in individuals aged 26 to 44, which was about 200 days in terms of median cumulative use. And we also presented the 25th and 75th percentile as reference. We observed pretty substantial concomitant use within this population. Many of them were also using antidepressants or benzodiazepines. So again, this was to help us identify individuals who might be more vulnerable to certain adverse events. The final analysis within this agenda item is to look at prenatal and congenital syphilis screening and treatment. And this was based on some concern that, well, the incidence of congenital syphilis has risen pretty dramatically in the past 10 or 15 years. And it's a condition that is preventable if you screen well and treat well. So we did this separately within the Medicaid population and the commercially insured population. If you look at the lower left-hand side of your screen, you see that there was sort of pretty obvious differences between the Medicaid and commercial population. Neither of them reached the 100%, which I think is the recommended sort of number that you should strive for. The good news is that repeated screening during the second and third trimester seem to be increasing in both populations. So that is something to highlight. And there was also some differences in syphilis treatment in pregnancy between the Medicaid and commercial populations. As mentioned earlier, we onboarded Medicaid as part of this contract, so we are now able to look at this big population, and the population also has a lot of pregnancy, so which allows us to do analysis like this. So signal identification. So only spend a few minutes to give you an overview of the work that we did last year. So as I mentioned, we completed 6 analyses last year. I'm highlighting 4 of them here. We use tree scan approach, which allows us to screen for thousands or tens of thousands of outcomes simultaneously using either a self-control or an active comparator cohort design. So this method does a pretty good job at reducing false positive rate. So for the analysis that we did, the 4 that I'm highlighting here, we found 1 alert. So there is sort of a process that we use to follow up on a signal or alert when it arises. So we will always do a clinical review, and if necessary, a more formal study could be designed or launched. So for this set of signal identification activities, we found a signal between risankizumab and the calculus of gallbladder without cholecystitis. So this is based on the ICD-10 definition. And what we did next was that we used what we call the patient episode profile retrieval tool to pull the pharmacy and medical claims history and clinical information of the patients around the time they initiate the drug and around the time they have the outcome of interest. So for this, after clinical review, it was determined that this alert was probably incidental to the orders, like orders of radiology in support of hospitalization for more serious events. So this was something that the clinician concluded when they reviewed the claims profile of the patients. So for this, no further investigation was deemed necessary after the clinical review. So again, it shows that through these signal identification activities, we were able to look for things that we did not think of or we did not suspect. And the approach that we are using is doing a pretty good job at reducing the false positive signals. So the third group of activities is related to cannabis use. I'm going to highlight a number of them. So the first one was a literature review. So this was in support of a larger effort to potentially reschedule cannabis product through what the government called an X factor analysis. So we did a literature review for the agency to look at the safety and effectiveness of medical and non-medical use of cannabis products. I won't go into the detail or the conclusions. So hopefully the review will be in the public or in the peer review domain soon. I know that that has been in the work for a while now. We also did some analysis within the Sentinel system. So this first one was looking at trends in encounters or substance poisoning within the Sentinel database. So we looked at cannabis products and other substances like alcohol and benzodiazepines. So the cannabis results are shown in gold. The figure at the bottom might be a little bit hard to read, but it tells us that there is an increased trend in the number of encounters for cannabis poisoning during the study period of 2016 and 2022. When we look deeper into this, we found that cannabis-related disorders or poisonings was increasing during the study period, and they seem to be driven mostly by outpatient encounters, which was shown on the lower left-hand side of your screen. And if you look at the figure on the right-hand side, you'll notice that these encounters were mostly by individuals who are at the youngest age group, which might not be too surprising based on how I understood these products are being used. So this work contributed to the Department of Health and Human Services sort of overall recommendation to reschedule this product. So the report, I think, is in the public domain, and the links are in the earlier slide. So if you are interested, you can see how Sentinel contributed to this effort. I will end with just a very brief review of the expansion activities that we did last year. The first one was the pregnancy algorithm and tools that we are using in Sentinel. We have a pregnancy algorithm that helps us identify pregnancies in electronic healthcare databases. So an earlier version focused on live birth delivery because we were very focused on linking mom and baby and studying the effect of medication during pregnancy and infant outcomes. So in a new version that we are working on now, we expanded the algorithm to identify non-live birth deliveries. So the numbers at the bottom show you the breakdown by pregnancy outcome when we apply this new algorithm in the market scan data. That makes sense based on how we understood the different types of pregnancy outcomes in clinical settings. We also enhanced the analytic tools to allow us to do more. An earlier version of the tool focused on binary maternal and infant outcomes. We now have the ability to look at time to event maternal outcomes. We can also now look at utilization and other events in the postpartum period. The earlier version focused on the period during pregnancy and before pregnancy, but now we can look further after pregnancy ended. The final thing that I'm going to talk about is our work linking National Death Index with the CMS Medicare and Medicaid databases. So we already have a number of data partners populate death and cause of death table in the Sentinel system. And you probably know that Medicare actually has a pretty good capture of fact of death information. But neither Medicare or Medicaid data had good capture of cause of death information. And the mortality information was also pretty limited within Medicaid in terms of cause of death, fact of death, I'm sorry. So by linking the National Death Index with these two big data sources, we are able to improve the capture of cause of death pretty substantially. So we went from 0 in Medicare to over 70 million records of cause of death, and from 0 in Medicaid to 4.6 million. And overall, we went from just under 5 million records of cause of death to over 80 million records. This allowed us to study mortality and cause-specific mortality in Sentinel, which was something that we were not necessarily able to do previously. So here is a more detailed breakdown of what we have before and after NDI linkage. I would draw your attention to the line of immediate or primary cause of death. So we went from about 3% to 18%. So this is important because a number of safety issues might be interested in looking at cause-specific mortality. So having cause of death information really sort of improve what we could answer in the Sentinel database. So this is all I have. So it takes a village. Actually, it takes multiple villages to do what I just presented. So I'm just going to go through this semi-slowly so that you can appreciate the number of people from our FDA colleagues, the data partners, and the Sentinel Operations Center to complete the work that I just presented. And with that, I thank you for your attention.
Great. Thank you so much, Darren, for that wonderful presentation as well. So we do have a few minutes for questions. So I will just take us to, apologies, went too far. There we go. Okay, we'll take us to the discussion questions. So first, I know that we had a question we were hoping to ask all of you on how have the Sentinel Innovation Center and Sentinel Operations Center coordinated efforts to address overlapping goals? So, see if anyone would like to speak first.
Oh, so I can start first. So as Rishi mentioned, one of the first tasks that we did was to look at the ARIA insufficiency summary so that we can identify the gaps, and then we can try to fill the gap with the real-world data, evidence data enterprise. And as Sebastian mentioned, some of the work that we are doing in year 5 leveraged the Sentinel tools in addition to the NLP and machine learning work that we did, sort of more with the ad hoc programming effort. So the collaboration, I would say, is pretty seamless. We meet almost too often, but we are also neighbors, so there's a face-to-face meeting as well. So this is just from our operational perspective. So we identify gaps, and hopefully, I hope that the Innovation Center could fill them.
Wonderful. Thank you so much, Darren. Rishi, did you want to add anything?
Yeah, I just want to say we see ourselves as just a test bed for the things that hopefully Operations Center can really use in routine care, or routine practice, I should say. And yeah, so we focus very much on bringing in new types of data sources, developing new analytic methods that are able to leverage those types of data sources and eventually rely on the expertise of the Operations Center that they've developed over the 10 or so years to guide us in terms of how to work with the FDA and how to seamlessly implement some of these in routine operations.
Great, thank you so much. So I know a number of you put questions in the Slido. We really appreciate that. They seem to coalesce conveniently around a question that we had prepared already, which is what are the immediate next steps or data infrastructure enhancements needed to advance a real-world evidence data enterprise? So I know Sebastian, Rishi, really targeting towards you all.
You want to take this?
Why don't you go first?
Okay, yes. So I think as Sebastian was going over the slide that shows some of the challenges that we face. So we built this new shiny infrastructure that we want to leverage all the time, but we cannot because we are limited by the numbers. And so I think the next step would be to expand our footprints with the number of lives covered, which allows us to kind of expand to these newer territories of not as frequently used medications and rare outcomes. So currently we are mostly in the areas of these common conditions like diabetes, heart failure, those types of things. That's not uncommon. But expanding our footprint to bring in newer types of data sources or more data partners would allow us to address more of these questions.
If you just go also beyond Sentinel, I think pharmacoepidemiology, when you work with secondary data in a non-randomized setting, we have done enormous progress over the last 20 years to understand what we need to do for causal inference in order to come to causal conclusions with our analyses, right? And I think also our audience is understanding these methods much better than 10 or 20 years ago. The real work is in getting better data, more robust data, more granular data, and also understanding the quality of the data. And quality of the data is always this fussy word, quality. What it really means is when it comes to causal inference, we need to understand the measurement characteristics of individual measurements of the health outcomes. We want to know sensitivity and specificity of the endpoint, which is exactly why one or two of those use cases that I went through in fairly rapid cycles, this whole expedited validation of codes and claims data is so critically important. We need to better understand the quality of the data in quantitative ways, because then we can do quantitative bias analysis. We understand how far are we away from the true parameter that we want to estimate. So hence, exactly just what Rishi just said, underlining that the implication for Sentinel is also to include more granular data assets often by linking different types of data together, right? And the technology for that is actually quite trivial with tokenization, things like that. It's often the privacy concerns in the willingness of partners to work together in sharing their data in order to make that happen. But that's clearly the future of secondary data analysis for understanding the safety and effectiveness of medications.
Wonderful, thank you so much. And then one more question we received from the audience, so if you could speak a little bit more to this one. Can more be said about how the real-world evidence CE complements the Sentinel distributed database? Will Sentinel routinely use both sources for analyses, so sufficiency, descriptive, inferential?
Yeah, so I can start, and Sebastian and Darren can add. So that's our hope. That's our hope, is that we are complementary, because there are specific questions that just cannot be studied using only claims data, like the acute pancreatitis example Sebastian was describing, where to define the outcome, you need information from the EHR. So those types of questions we think can be better suited for RWED alone. But then there are other questions which can be studied with claims data, just owing to the size, but leave some uncertainty, like the unmeasured confounding question, or how valid are you capturing some outcome. So those types of questions, I think, are perfect examples where both data assets can be used simultaneously, actually.
It's clearly complementary, right? But we cannot divorce data from the analytics. We have to see this together, right? And I'm worried that the conversation goes too strong in, all these data sources are interchangeable and you can just pick one and to open a drawer. And that's not the case. We need to really understand each data source in order to fit the methods that we're using. And I think the Operations Center has done a splendid job over the last 15 years in helping in translating a raw research question into something that can be operationalized in claims data, in claims plus EHR data, et cetera, right? This connection between the research question and the data source available in the middle, that is also a key part of Sentinel.
Great, thank you so much. So we just have a couple minutes left. Are there any final thoughts you'd like to leave the audience, or words you'd like to share as the program progresses throughout the day for the rest of the speakers?
Oh, I can keep on talking for hours. I think what has become obvious in all of our presentations is the advantage of having the continuity of claims data and the granularity of EHR data, and you can expand this to many other data sources, the NDI linkage, you might have social determinants of health information, you might have other financial information, whatever is available and ethically available for linkage is fair game and is improving the validity and the impact of the research that we have. There's absolutely no question about that. These data sources, however, need to reach a certain size as well. It's not just the granularity, it's also the quantity of the information, as we have illustrated with our currently 21 million lives that we have linked EHR and claims. You can do a few use cases, and you saw some in the diabetes space, which is a fairly prevalent condition with medications that are frequently used. But if you go to another use that Darren has shown, for example, the 20 million lives is too small, right? Particularly then also if you look at newly marketed medication, which is the most interesting space, where we have the most desire for more knowledge of how medications work and how effective and safe they are in clinical practice. We are dependent on how fast this medication gets picked up. And if this is slow, then do we want to wait 10 years because we have only 20 million lives? No, we want to wait maybe 2 years, 1.5 years, with 100 million lives where we have linked claims and EHR data, right? Which is why it was this year 5 project where we dive deep into the health information exchanges. But why I'm so excited about that, because that seems to be a data source that is truly scalable to the entire nation. Appreciate it. We need patience for that. I totally get that, right? And Oklahoma is maybe a prime example. But the trend, and I always said when I started in this field about analyzing secondary data, the data only getting better and more. It's a monotonic function. It's only going up. The question is how fast is it going up, right? And hence, we should pay attention to health information exchanges.
Wonderful. Thank you so much, Sebastian. All right, Rishi, Darren, any final quick thoughts?
I can say something as always. So I think that I can speak for many people. We are very much interested in how FDA envision the next Sentinel system to look like. As the keynote speaker mentioned, the goal is to be more flexible and able to use an even more diverse set of data sources, not just claim, not just EHR, not just link claims EHR, but other types of data sources as well. So it'd be good to see what the vision is. I would tell you from my personal observation is that in the process of putting these slide decks together, I personally was just blown away by the level of rigor and the type of work that we are able to support. And FDA is a tough crowd. The standard is really high. So I think that in many ways, Sentinel, the Operations Center Innovation Center's work is setting some sort of standard for pharmacoepi community in general. Because I'm also doing my own research, and when I compare my own research with what FDA is asking for, you see some sort of notable differences. And I think that it's always a good idea to set the standard that high so that we can all know what is regulatory grade.
Great, thank you so much. Rishi, 10 seconds.
Yes, so I just want to quickly mention one thing which doesn't get mentioned frequently. So people talk about use of machine learning and large language models and AI and stuff like that. But I think what you need for that is a sustainable infrastructure of data that is readily available for use so you can implement that. And that doesn't get talked about frequently. And one of the efforts that we're really proud of in the Innovation Center is actually converting all the free text data that we have from the 4 centers into readily analyzable format, which takes minutes to give you feasibility counts because we have the metadata extracted from the free text notes, and that allows us to quickly move to the NLP model development, which is described in a paper that was recently published and I cited. So thank you for this opportunity.
Yeah, wonderful. All right, thank you so much to all our wonderful speakers. And we'll now transition to a 15-minute break. We'll reconvene at 11:15 a.m. Eastern Time, and we'll have a wonderful moderator, Christina Silcox, who will be welcoming you to that next session. Thank you.
All right, everybody, welcome back. I'm Christina Silcox. I'm the Research Director for Digital Health at the Duke-Margolis Institute for Health Policy. I am a dark-haired woman wearing a red shirt and black pants. This session is entitled Vaccine Monitoring for Regulatory Impact for the Best System. I'd like to get things started by introducing the panel. We have Joanne Gruber, online, so you're going to hear her. An epidemiologist in the Office of Biostatistics and Pharmacovigilance in the CBER surveillance program at the US FDA. So she's going to be behind us in the screen. We have Patrizia Lloyd, health statistician on the Office of Biostatistics and Pharmacovigilance at the Center for Biologics Evaluation and Research at the US FDA. We also have Yoon Liu, the Deputy Division Director at the Division of Analytics and Benefit Risk Assessment in the Office of Biostatistics and Pharmacovigilance at FDA. And finally, we have Mao Hu, a policy researcher at Acumen LLC. So we're going to start with our speakers giving some presentations and starting things off with Joanne. Joanne, we can't quite hear you yet. You did? Try one more time.
Hello.
Yes, we can hear you now. Excellent.
Can you hear me? Okay, great. We did a quick sound test, but it's good to check again. Thank you. And good morning, everyone. I am a white woman with dark brown hair and glasses. And as Christina mentioned, I am Joanne Gruber. I'm an epidemiologist in the Center for Biologics Evaluation and Research in the Office of Biostatistics and Pharmacovigilance. Today, I'll be starting off our session on vaccine monitoring and the regulatory impact of the BEST system. Next slide, please. Hold up, great, thank you so much. The BEST initiative and its studies are funded by the U.S. Food and Drug Administration. There are no potentially conflicting relationships to disclose, and the findings and conclusions in this presentation are those of the authors and do not necessarily represent the official position of FDA or Acumen LLC. Next slide, please. So here is an outline of our session. I will begin the session by discussing the overview of the BEST initiative, our recent advancements, and the regulatory impacts that we've seen in 2024. Next, my colleague will discuss RSV vaccine safety surveillance among older adults. Following that presentation, we'll have a presentation on RSV vaccine effectiveness among older adults. And finally, we'll close out the session discussing our 2025 vaccine surveillance activity plans. Next slide, please. As I mentioned, I'll first begin with an overview of the BEST system and our advancements. Next slide, please. The FDA Center for Biologics Evaluation and Research, or CBER, regulates a number of biologic products, including vaccines, blood, components and derived products, human tissues and cellular products, gene therapies, and xenotransplantation products. The CBER mission is to evaluate and ensure biologic product safety and effectiveness through active surveillance. And within CBER, as part of the Biologics Effectiveness and Safety, or BEST initiative or system, the CBER Active Surveillance Program conducts studies to build and utilize a national post-marketing surveillance system to provide data for evidence-based regulatory decisions. Next slide, please. As I mentioned, the CBER Active Surveillance Program conducts studies to understand the safety and effectiveness of CBER-regulated products. These surveillance studies are done through partnerships with our federal partners, including the Centers for Medicare and Medicaid Services, the Veterans Administration, the Centers for Disease Control and Prevention, and then through multiple contracts, we also work in partnership with organizations that are part of the Biologics Effectiveness and Safety, or BEST initiative, and those agencies include Acumen, RTI, CBS Health, IQVIA and Carillon Research, Optum, Columbia University, and the Odyssey community, as well as other academic partners. Next slide, please. BEST has access to a variety of healthcare data sources, including administrative claims data from Medicare and large commercial insurance companies that cover over 100 million people and a large proportion of the US population. We also have access to electronic health record data sources, as well as linked claims EHR data sources. This table shows a list of our data sources and the population size they cover. The data lag of each data source varies from a few weeks to a few months, depending on the source. Next slide, please. The databases are part of a distributed data network. Data are maintained by and reside behind firewalls of each of our data contributing partners in our network, and our data partners are able to transform their source data into a common data model and permit access to the data through the use of a standard query approach. In addition to our claims and EHR databases with our short data lags, we have an expandable and adaptable common data model, and BEST also has on-demand analytic capabilities to tailor each analysis to meet our needs, as well as access to medical charts to validate health outcomes and other clinical information. Next slide, please. We continue to find ways to improve the agility, productivity, and efficiency of the BEST infrastructure. In the last year, we have continued to work with our partners to find ways to shorten the data lag for some of our databases to provide more rapid access to information for our safety surveillance. In addition, we have expanded our relationship with several state and local immunization information systems to not only capture additional jurisdictions, but additional vaccinations within those jurisdictions, including RSV and influenza vaccination. And this is in addition to the already included COVID-19 and Mpox vaccinations. We have also maintained successful linkages of mothers and infants in our claims databases. And in addition, this year we have implemented large-scale execution of self-controlled case series studies with multiple exposures and outcomes. And we continue to evaluate and execute novel methods for signal detection, including a relatively new method that we'll implement this year that will be discussed later in the session. Next slide, please. So next, I'll talk about the regulatory impacts of the BEST system during 2024. Next slide, please. BEST studies continue to generate a significant level of scientific information to help understand the safety profile of vaccines in a timely manner. We also generate data to understand vaccine effectiveness profiles. Specifically, our work has important regulatory and public health contributions, including providing data to inform the CDC Advisory Committee on Immunization Practices, or ACIP, recommendations, contributing information to inform updates to drug labeling, and supporting EUAs and approvals. We also work to share our data with our international regulatory partners to improve safety and effectiveness of biologics globally. Some examples of these studies will be presented later in the session, but I'll briefly discuss some examples of the regulatory and public health significance of the BEST work in the next few slides. So last fall, the BEST team designated and designed and implemented a study to understand the safety of RSV vaccines administered to the older population. The results of this work were presented at the CDC ACIP meeting in February, June, and most recently October 2024. The studies presented key information to inform the public health recommendations on the use of RSV vaccination in this population. And additional details of these of this study will be presented later in the session. Next slide, please. In addition, the BEST team also shared information on a safety study of the pneumococcal conjugate vaccine 20 or PCV20 vaccine at the CDC Advisory Committee meeting in February 2024. Next slide, please. Our near real-time monitoring of the pediatric COVID-19 vaccination was published in JAMA Open Network and found a signal for febrile seizures following mRNA COVID-19 vaccination in young children. This work was presented at the Sentinel annual meeting last year, and during that time, the BEST team was also conducting a follow-up study to evaluate this potential signal, and results of that study are available via preprint. The combined results of these studies were used to inform a change to the labeling to indicate a possible risk of febrile seizures following mRNA COVID-19 vaccines in young children. Next slide, please. In addition, BEST continues to monitor myocarditis, pericarditis following COVID-19 vaccination. We continue to share these data and information used to support the review memos for the updated COVID-19 vaccinations. Next slide, please. So in summary, the BEST initiative facilitates CBER's mission to ensure biologic product safety and effectiveness through active surveillance. BEST continues to generate data for evidence-based regulatory decisions in a timely manner, and CBER it continues to enhance and expand BEST infrastructure and capacity to remain agile and efficient. Now I'll pass it off to Dr. Patrizia Lloyd, who will describe the details of the RSV safety study that I mentioned earlier. Thank you.
Dr. Gruber, let's see if I can advance. Okay. And my slides, here we go. Okay. So thank you very much. My name is Patrizia Lloyd, and I am happy to be able to present our post-market evaluation of Guillain-Barré syndrome, or GBS, following respiratory syncytial virus, or RSV, vaccination among adults aged 65 years and older. So here's our brief outline. So I'll provide a little bit of an introduction and then also share the results from our observed versus expected and our end of season SCCS analysis results in comparison to our early season results, and then provide a discussion and then some conclusions. So as an introduction, RSV can cause lower respiratory tract infections, which could lead to pneumonia and bronchiolitis in adults. And annually 60,000 to 160,000 RSV hospitalizations and 6,000 to 10,000 deaths among adults aged 60 years of age and older, compared to an estimated 140 to 710 flu hospitalizations and 12,000 to 51,000 flu deaths annually. There were 3 RSV vaccines that were approved for use in the U.S. In adults aged 60 years and older. Those include the RSV pre-F3 AS01 or GSK or Rexv, the RSV pre-F or Pfizer's Abrysvo, and then the mRNA 1345, Moderna's Mrezvia. I will note here that the presentation includes results of our study that included vaccinations through January of 2024, which was prior to the approval of Mrezvia. So our presentation really only focuses on the first 2 Rexv and Abrysvo vaccines. So the pre-licensure clinical trials that were done for Rexv and Abrysvo did identify a small number of GBS cases for those 2 vaccines, and there were also reports that were submitted to the Vaccine Adverse Events Reporting System, or VAERS, that identified higher GBS rates following Rexv and Abrysvo vaccination that were higher than the expected background rates. So just to quickly give an overview of the 3 analyses that I'll be presenting, these are our post-market analyses to look at the safety of RSV vaccines among Medicare fee-for-service beneficiaries aged 65 years and older. In our observed versus expected analysis, which was the first analysis that we presented in February, this included vaccines that were administered through December 2nd, 2023, with data through the same date. There were about 2 million doses of vaccines, 1.4 of Rexv and about 680,000 of Abrysvo. and less than 24 GBS cases were observed. And our early season SECS analysis has included vaccinations through October 22nd of 2023 with data through April 6th of 2024. This included about 1.2 or 1.3 million doses with about 28 GBS cases that were observed. In our end of season SECS analysis, most recently presented at the ACIP meeting, the number of vaccinations that were included were administered through January 28th of 2024. The data through date was July 13th, 2024. There were about 3 million doses that were administered and 95 GBS cases that were observed. So first, I'll just talk very briefly about our observed versus expected analysis. This crude analysis really allows for us to look at the potential safety signals, but it uses an aggregate historical comparator rate, and this increases our potential for confounding, and it doesn't establish a causal association between RSV vaccines and GBS. And in this analysis, what we're doing is we're comparing our estimated observed incidence rates to the historical comparator or expected rates so that we can obtain incidence rate ratios with 95% confidence intervals. And in this study, we evaluated the risk of GBS following one dose of either Arexvy or Brisvo using a retrospective cohort design with a 2022 historical comparator. We estimated the GBS positive predictive value adjusted rates based on multiple imputed data sets. We used PPV from a previous study that was conducted where the PPV based on chart review was about 71%. Our results are summarized here. Again, we had about 2 million doses that were administered and less than 24 GBS cases. I want to just point out that in our observed versus expected analysis following Arexvy, the incidence rate ratio is 2.76, and it was statistically significant. Following Brisvo, the incidence rate ratio was 6.94, and that also was statistically significant. When we adjusted for PPV, the results following Brisvo remain statistically significant. And you can see for both Arexvy and Brisvo, the estimates didn't change very much, but our confidence intervals did change with that PPV adjustment. I want to now switch over to talk a little bit about the self-controlled case series design. In our SCCS design, only individuals who had a GBS event are included in our study, and specifically a GBS event during the observation period. This figure here just illustrates what our SCCS design looks like. So we defined the risk interval as 1 to 42 days following vaccination with either of the two vaccines, and our control interval as days 43 to 90. We also define our clean window as the 365 days prior to the GBS event. And again, our study start date was the date of the approval for the two vaccines, about May 2023. Our our study end date was July of 2024. We included vaccinations through January 2024, and we observed GBS outcomes through April of 2024. Just to give you a little bit more information about this design, again, we were looking at Medicare fee-for-service beneficiaries that were aged 65 years and older. They were enrolled on the date of their first observed RSV vaccination and during the 1 year prior to vaccination. And again, they were incident GBS cases during that observation period, days 1 through 90, post-vaccination. And they were vaccinated with either Arexvy and Brisvo. Just to highlight that our GBS outcome definition, since we're using claims data, it came from the inpatient care setting. We use the primary physician only. In our analyses, we calculated the incidence rate ratios. We also estimated the attributable risk per 100,000 doses and 100,000 person years. We also performed adjustments for outcome-dependent observation time, or the Farrington adjustment. We also adjusted for seasonality and PPV. We also performed a chart-confirmed analysis based on medical record review. and that also included variant and seasonality adjustments. We also conducted a secondary analysis, again calculating our incidence rate ratio and our attributable risks, but stratified by same-day concomitant vaccination with updated COVID-19 vaccine, updated influenza, as well as pneumococcal and shingles vaccines. So in this figure, we're looking at the weekly uptake trends of Arexvy and Abrysvo. In green are is Arexvy, and in blue, Abrysvo. And the first dotted line that's shown here is the vaccination cutoff date for that early season analysis that was performed. The second dotted line is the end of season vaccination cutoff date. So that was in January of 2024. And you can see between these two periods, there are a lot more vaccinations that were administered. So in our end of season analysis, we have a lot more doses that we're able to look at. You can also see in purple is the end of the 90-day observation period for the end of season analysis. And then in brown is the additional 11 weeks for 90% complete claims. Just to highlight again, as I mentioned earlier, in our early season SCCS analysis, we had about 1.3 million doses that were administered. More doses administered, more of the Arexvy doses were administered than the Abrysvo. There were 11 cases that qualified for the SCCS analysis among the Arexvy group, and 17 GBS cases that qualified for the analysis in the Abrysvo group. In our end of season analysis, we have a total of 95 cases, GBS cases that were observed during the observation period among 3.2 million doses that were administered. 56 were observed following Arexvy, and 39 observed following Abrysvo. As I mentioned, we were also able to conduct a medical record review, and here are our results. In the top table are the results for case classification, and you can see of the 95 cases that were observed, and we requested all of those records, 75 records were received and adjudicated. Of those, 51 were chart confirmed using the Brighton collaboration clinical case definition for GBS. And 24 were either determined to have insufficient evidence or deemed not to be a case, and 20 records were not returned. We also calculated the positive predictive value, or PPV, based on our records that we received. In the total, or among the total 75 that were received, we had an overall PPV of 68%. When we look only at those that were in the risk interval, we had a 62.3%, and in our control interval, our PPV was 81.8%. So now I want to summarize the results of our early versus end of season results for looking at GBS and following Arexvy. And you can see in this forest plot, we're presenting results from our end of season analysis up top. There are two analyses that are presented, and in the bottom are our early season SCCS analysis. In red, I just want to highlight here, these are the results from the analyses that includes the most adjustments. So in this first incidence rate ratio and that we see here, this comes from an analysis that adjusted for seasonality, using the Farrington adjustment, adjusting for PPV, and including chart-confirmed cases and non-returned cases. And you can see here that we did observe a statistically significant elevation in GBS risk following Arexvy. Incidence rate ratio is 2.46 with a confidence interval of 1.19 to 5.08. You can see also that in our early season SCCS analysis, the estimate didn't change very much, or it wasn't very different from what we see in our end of season analysis. However, the confidence interval is very wide. So by including more GBS cases in our analysis, we were able to improve the precision of our estimate. And now I'm going to show you a similar slide following or looking specifically at results following Abrysvo vaccination. And again, what we see here in our end of season SCCS analysis is that there was an elevated GBS risk. However, it was not statistically significant. We estimated an incidence rate ratio of 2.02 with a confidence interval of 0.93 to 4.40. And you can see that these results are similar if we looked only at chart-confirmed cases, which is that second analysis right underneath. Both of those analyses, they were not statistically significant. However, you can see that it did appear to be elevated. So this is just a table to summarize results from both of the two slides I showed previously, looking at Arexvy and Abrysvo. I want to just point out the attributable risk estimates that are presented here. So the attributable risk per 100,000 doses following Arexvy was 0.65, and following Abrysvo, 0.90. And also, looking at the attributable risk per 100,000 person years was 5.71 following Arexvy and 7.82 following Abrysvo. Before jumping into the results from our secondary analysis, which looked at stratified by concomitant vaccination, I just want to share the number and percent of those in each of the vaccine groups that received a concomitant vaccination. Again, concomitant vaccination is being vaccinated on the same day with one of the 4 vaccines that I mentioned, so including updated COVID-19, influenza, including pneumococcal and shingles vaccines. So you can see among cases that received the Arexvy vaccine, 36% of those also received another vaccination on the same day. And among Abrysvo vaccinees, you can see that 49% also received a concomitant vaccination. So now I want to present the results for this analysis. In this slide is a forest plot, including those with concomitant vaccination, without concomitant vaccination for the 2 vaccines. So you can see here that when we look at those with concomitant vaccination for both Arexvy and Abrysvo, the results are not statistically significant. However, we do see an elevated incidence rate ratio, indicating that there appears to be some elevation in GBS risk. However, when we do look at the results without concomitant vaccination, we see that the results, again, are elevated. However, they are statistically significant. What we found in this analysis was that there really was no evidence of a difference in GBS risk among persons with and without same-day concomitant vaccination with RSV vaccines. And just to summarize our results following Arexvy with concomitant vaccination and without concomitant vaccination, you can see in this slide the numbers are very small. So when we start looking at a stratified analysis, we're looking at a very small number of cases. I want to just point out here again that our attributable risk estimates are shown. For the sake of time, I'm going to just move along and also show you the results for following Abrysvo, again with and without concomitant vaccination. And again, the number of cases in each of these groups are very small. To share now the strengths and limitations of this study, this SCCS design provides robust adjustment for potential time invariant confounding. We're also using a large database using the CMS claims database, and that provides more precise evaluation of GBS. Our study findings are generalizable to the US population aged 65 years and older, and by using medical record review, we were able to improve our classification of GBS. There are also some limitations of the study. First is that there still may be potential misclassification of GBS in administrative claims data. Also, the study wasn't intended to make comparisons between the 2 vaccine products. Also, the incidence rate ratios that we presented, they may be sensitive to the number of records that were returned and adjudicated through the medical record review process. There's also potential misspecification of the post-RSV vaccination risk and control intervals. There's also potential for residual confounding, and also our attributable risk estimates based on a number of small cases may be difficult to interpret. Just to summarize the totality of the evidence from the 3 different analyses, in our observed versus expected analysis, We did identify an elevated risk of GBS observed following both vaccines, but these results were not statistically significant for Arexvy when we adjusted for PPV. In our early season analysis, our SCCS analysis, we also identified statistically significant elevation in GBS risk that was observed following RSV, following Abrysvo vaccination, but these results did not remain statistically significant for Abrysvo when we adjusted for PPV-based multiple imputations. In our end-of-season analysis, there was a statistically significant elevated incidence rate ratio that was observed for GBS following vaccination. The GBS risk was elevated, yet not statistically significant when we looked at Abrysvo, but was significant when we with Arexvy. The results remain the same when we restricted to confirmed GBS cases through medical record review. And there is no evidence of a difference in GBS risk among persons with and without same-day concomitant vaccination. So in conclusion, our findings suggest an increased GBS risk following Arexvy and Abrysvo among adults aged 65 years and older. These results are consistent with pre-licensure clinical trials and surveillance systems such as VAERS. And our end-of-season SCCS analysis results, they're largely chart-confirmed from a medical record review, and they include about 3 times more vaccine doses and GBS cases compared to our early-season SCCS analysis results. GBS risk following vaccination with RSV and following Arexvy and Abrysvo is rare, less than 10 cases per 1 million vaccinations. And lastly, there was no difference in GBS risk among persons with and without same-day concomitant vaccination with RSV vaccines. I just want to thank everyone who contributed to this study, and I'll be happy to take questions later. Thank you so much.
Well, good morning. I'm Yunlu from FDA CBER. Today I'm going to talk about real-world effectiveness of RSV vaccines among older adults. So this is my disclaimer. Every year, RSV infection contribute to a large number of hospitalization and deaths among older adults. So back in May 2023, FDA approved 2 RSV vaccines, GSK and the Pfizer vaccines. So objective of our study is to evaluate real-world effectiveness of those RSV vaccines among older adults. Because we are going to use real-world data to generate real-world evidence, I want to share with you our approach to generating RWE. So we first start with asking the right question. And then we look at the data, we use the fit-for-purpose data and try to minimize bias in the design stage. And then we conduct appropriate statistical analysis. We also plan sensitivity analysis to see how robust our results are. We also conduct additional analysis to detect and quantify residual biases. And I want to emphasize on the iterative nature of this approach because analysis we conducted actually will help us understand the data better to inform us about future study designs and statistical analysis. Because we're interested in evaluating RSV effectiveness among older adults, so we use Medicare claims data, which covers a vast majority of individuals aged 65 years and older. And the Part D can capture RSV vaccination status. That's our exposure. And using Part A, hospital insurance, and Part B, medical insurance, will be able to capture our RSV outcome, as well as many important covariates I want to address in the analysis. For our study population, we focus on community-dwelling individuals who don't live in nursing home. We also exclude individuals who have end-stage renal disease because those 2 populations are very different from community-dwelling. Because the claims data can capture RSV vaccination status pretty accurately, it enables us to conduct a retrospective cohort study comparing vaccinated versus unvaccinated individuals. So our study period starts from the first Sunday in August. That's August 6, 2023, and lasts until March the 2nd, 2024, which is a Saturday. So our definition coincides with the CDC's week definition, and also when we use 4 weeks data, it counts 4 days of the week, in fact. For our studies, we recruit everyone in the study who are all unvaccinated with RSV vaccines. So basically, we exclude anyone who are vaccinated with RSV vaccines before the start date. We also allow a person to change from unvaccinated to vaccinated cohort based on their vaccination status. So we have time-varying RSV exposure. This will also allow us to control for immortal time bias. For outcomes, we focus on severe RSV outcomes, RSV-related hospitalization, and death outcome. So as I mentioned earlier, it's very important to understand the data and minimize bias in the design and analysis stage. So outcome misapplication could be a concern. Historically, there has been under-capture of RSV outcome in the claims data. So our solution is focused on severe outcomes such as hospitalization and death outcome. False positive RSV diagnosis could be another potential issue because based on our study using COVID and influenza, we have observed that there is underestimation of vaccine effectiveness when there are false positives. So our solution is use very similar approach as in COVID and influenza V study. We focus on a time period that has high virus circulation. We also conduct sensitivity analysis to test alternative definition of high RSV circulation. And also by using severe outcomes such as hospitalization and death outcome, it is also less impacted by false positives. Differential health-seeking behavior is a potential unmet confounding because vaccinated individuals may tend to seek healthcare more compared with unvaccinated. That could bias the result towards none. So we conducted a subgroup analysis looking at individuals who had prior influenza vaccination. So we use prior influenza vaccination as a surrogate for health-seeking behavior. We also, by restricting our outcome to severe outcome, they're less likely to be impacted by this health-seeking behavior. So for our statistical analysis, we adjust for many covariates such as demographics, socioeconomic status, health conditions, as well as geographical conditions. And we use prevalence score weighting to address imbalance of cohorts. And in our outcome model, to account for residual confounding, we also use a double robust approach by including all the prevalence score covariates in the outcome model as well. And we use a margin structure model around a Poisson regression. Medicare data is large. So in our study, you can see that we have about 11 million unvaccinated individuals, 2 million GSK vaccinated cohort, and also about 0.9 million Pfizer vaccinated cohort. After prevalence score weighting, in general, covariates are well balanced, but there are some covariates that are still remain imbalanced after weighting, which include the census tract level RSV circulation, census tract level population density, and also prior influenza vaccination and a prior COVID-19 vaccination status. But I want to point out that because prior influenza vaccination and prior COVID-19 vaccination actually is a strong predictor of receiving RSV vaccines, we did not include them in the prevalence score model. We adjust for them in outcome model instead. So here is the preliminary primary analysis result about RSV-related hospitalization. So you can see that vaccines are highly effective against RSV-related hospitalization. The point estimate is 81.8% with a 95% confidence interval, 80% to 83.4%. And when you look at vaccine effectiveness by brand, you can see that, again, both vaccines are highly effective. And here is the result for the subgroup analysis, looking at the impact of potential health-seeking behavior difference. So you can see that when we conduct subgroup analysis among people with prior influenza vaccination, the magnitude of the VE is higher than the primary analysis. That is as expected because health-seeking behavior could result in underestimate of VE. But it's very reassuring to see that actually the magnitude of difference is very small. So the results are very similar for both studies, which means that differential health-seeking behavior actually has a limited impact on RSV related to hospitalization VE estimate. We also conducted sensitivity analysis, look at different alternate circulation rate, because when we conduct COVID and influenza VE studies, we have noticed that the observed VE actually is lower during low circulation. And here you can see that when we compare different definitions of RSV circulation for the primary analysis, we use 8 cases per 100,000 as a cutoff, low circulation with no restriction about RSV circulation, and high circulation we use 16 cases per 100,000, and the results are very similar. And for the first 3 studies, we look at the data after October 1st, 2023, to be consistent with a study CDC conducted in their end-stage renal disease population. And we also conduct another sensitivity analysis using all the study time. And the results are also, again, very similar. So this suggests that for RSV study actually false positive doesn't really impact the result much. So different from COVID and influenza studies, we don't need to restrict to high circulation periods. Okay. Because our study have large sample size, actually it allows us to evaluate rare outcome, including RSV-related death outcome. And you can see that it's highly effective against RSV-related deaths, and the magnitude is even higher compared with hospitalization outcome. That is also consistent as with the COVID-19 study that we conducted. We used 3 death definition. The first one is the most sensitive one, but less specific. So we consider deaths within 14 days of RSV hospitalization, and the second one is deaths within 7 days hospitalization, and the last one is the most specific one. Will only consider inpatient deaths. So you can see that the most specific one gives us the higher magnitude of the point estimate. This is as expected, but again, all the 3 estimates are really close to each other, so this is very reassuring. And our study have some strengths and the limitations. The strength is this is the largest population-based assessment of RSV-VE, and the results are readily generatable to people 65 years or older. And also we're able to evaluate rare outcomes, including deaths. But it also has some limitations because after pre-score weighting, there are still some remaining imbalance in RSV circulation, as well as some other varies, so there is potential for residual confounding, but the sensitivity demonstrates that actually our results are pretty robust. And because our study period is short, so we're not able to evaluate the winning effect in this current study. Okay. So in conclusion, our preliminary result found high vaccine effectiveness for Pfizer and GSK RSV vaccines against RSV-related deaths and hospitalization among older adults. And also the preliminary results are very similar across different RSV circulation definition, also health utilization groups. Our next steps, we are working on the winning immunity when we have more data, and also we'll conduct additional sensitivity or subgroup analysis and secondary outcomes. And because FDA also approved new Moderna vaccine in May 2024, so we're going to also evaluate effectiveness of the new vaccines. So I want to thank our FDA and the ICUMEN team members, and I'm happy to ask any questions after in the Q&A session. I will pass on to Mr. Mao Hu.
Hello, everyone. Thank you, Dr. Gruber. Thank you, Dr. Lloyd, and thank you, Dr. Liu. My name is Mao Hu. I'm an Asian American male wearing a dark suit and glasses. I work at Acumen LLC, which is the contractor of the FDA. I will be discussing methods development and future directions of vaccine safety surveillance on behalf of the team. This is an outline of my talk. So first I will discuss the 2024 vaccine safety surveillance methods. Then I will examine very briefly two examples, the RSV vaccine safety surveillance, as well as the pneumococcal 20-valent vaccine safety surveillance. And finally, I will discuss the planned 2025 vaccine safety surveillance methods. So for the 2024 vaccine safety surveillance, the methods used were roughly grouped into two categories. The first is descriptive monitoring of vaccine and outcome counts to assess feasibility of inferential studies on a continuous basis. And then the second is inferential analysis, which generally speaking involved comparison of post-vaccination risk against various comparators such as historical background rates, concurrent vaccinated persons in a control period, or self-controlled control periods. To speak more about these inferential designs, they are roughly grouped into these three categories. So first is observed versus expected designs, such as the one that was described by Dr. Lloyd, in which we compared persons in the risk period versus a historical aggregate background rate to provide a rapid comparison. The second approach is the concurrent comparator design, wherein we compare vaccinated persons in their risk period versus other vaccinated persons in their control period, where the control period is typically following the risk period. Finally, the self-controlled case series design compares vaccinated persons in their risk period versus self-matched control periods. So this is comparing within individuals. And as Dr. Anderson mentioned earlier this morning, this was used both with early season data and late season data to provide first rapid evaluation of risk following vaccination, followed by a more complete and comprehensive assessment of risk with a larger amount of data. This is a table of the study designs and a rough description of various strengths and limitations. So as mentioned, the observed versus expected design provides very rapid identification of elevated risk at the cost of a limited adjustment for confounding due to the use of a historical comparator. The concurrent comparator design is in the middle between the observed versus expected and the self-controlled case series, in the sense that as the comparison is among vaccinated persons, there is a reduction in bias due to confounding by indication and other factors that might vary by vaccination status, as described by Dr. Liu earlier. However, the adjustment is less robust compared to the self-matched, self-controlled case series design. And finally, the self-controlled case series design is the slowest. I think Dr. Lloyd had described the various components that go into the need to adjust that design for data delay, for example, the 11 weeks of delay necessary to observe complete GBS cases. So it's slower, but the design has very strong adjustment for time-fixed confounding. Let me briefly touch upon some elements of the RSV vaccine safety surveillance that Dr. Lloyd already covered. So here we have two tables, the first from the February 2024 ACIP meeting and the later one from the October ACIP meeting. The first table describes the observed versus expected analysis, and as you can see, there's rapid identification of high elevated risk. But you can see a very large difference in the incidence rate ratio estimate between the more biased OVE design versus this SCCS analysis that was conducted following chart review. So this is an example of the relative trade-off between these two designs in terms of rapid identification of elevated risk at the cost of increased bias. Second, I would like to briefly discuss the PCV20 safety surveillance that was presented by Dr. Forshee also at the February 2024 ACIP meeting. This figure displays the incidence rate ratio and posterior distribution from a Bayesian Poisson regression model for myocarditis, pericarditis following vaccination. This particular design was used to conduct multiple sequential analyses over time. And we can see in this figure that there was relatively little change in the incidence rate ratio in different data cuts. So this particular design can be very useful for identification of risk and characterization of it over different data cuts as the data system accrues additional vaccines and outcomes. So finally, I would like to discuss planned 2025 vaccine safety surveillance methods. So as before, we will use descriptive monitoring to continuously assess vaccination and outcome counts to assess feasibility of inferential studies. In commercial data partners where data delay is relatively larger, we will use observed versus expected designs in order to enable a very rapid detection of elevated risk using an aggregate historical comparator. And in Medicare, where we have relatively rapid data via the shared systems data system, we will use a concurrent comparator design in order to provide appropriate trade-off between bias and rapid identification of risk. Finally, these two signal identification approaches will be followed up by self-controlled studies, which will be used to evaluate selected outcomes with all appropriate adjustments as necessary. I would like to acknowledge Dr. Anderson, Dr. Forshee, the CBER surveillance team, CBER OBPV, our federal partners, my colleagues in Acumen, CVS Health, Carillon, IQVIA, Odyssey, and Optum. Thank you.
Thank you so much. Well, this has been such a fascinating session so far. I really appreciate it. I do want to remind people that we do have the Slido, so that if you have questions for those of you who are watching remotely, we also, for those of you who are here, you can use Slido if you'd like, but we also do have microphones. I'm going to get us started off and use moderator privative. And I would really, this was just so interesting, and I loved how you ended talking about, what you're thinking about in 2025. So I would love to just hear, and maybe we'll start with Yoon. What were some of the key lessons that you learned during your work in 2024 that can help better monitor vaccine effectiveness going forward?
Yeah. Can you hear me?
Yes.
Okay, good. Well, thank you for the question. because RSV vaccines are new, so it's our first time actually conducting RSV VE studies. And based on our investigation, what we learned is first, we need to understand the data well, understand the source of biases associated with these specific questions, because under capture of vaccine status actually is pretty typical for COVID vaccine and influenza vaccine, but it's not the case for RSV vaccine. So which enable us to conduct absolute VE study compared to unvaccinated. Because previous years, when we look at influenza vaccine effectiveness, actually, we had to conduct comparative vaccine effectiveness. We did not include people without vaccination code due to the potential bias. And also for RSV outcomes, the trend is also very different. So before we conduct VE study, actually, we look at disease burden of RSV across different time frame. We look at pre-pandemic, during pandemic, after pandemic. What we have noticed is there is very substantial undercapture of RSV outcomes, especially before pandemic. This is very opposite to influenza when there is false positives. And also there's an interesting trend, temporal trend. We observe that right now actually the undercapture of RSV status has been improved. Probably it's because the availability of some test kits that can actually test influenza, COVID, and RSV at the same time. So when we conduct studies, I think we'll also be mindful about the temporal trend because it's not a fix. It could change over time. So we think about study design, sorts of biases. We need to keep that in mind. Yeah. Thank you.
Thank you. Does anybody want to add to any of that? And then don't forget, if you're in the audience and you want to ask a question live, feel free to just raise your hand. Patrizia, can you tell us about your plans for studying the RSV vaccine safety in the older population for the upcoming year?
Sure, thank you. Well, I think Mr. Hu really, I think, pointed out a lot of what we're going to be doing in our next season. So we are going to be conducting our SCCS analysis also in the fee-for-service population for the age 65 years and older. And we would also look at the Medicare Advantage population as a potential other population that could provide some additional doses. So I think that's something that we are interested in exploring, as well as the concurrent vaccination or study as well.
Great. And kind of continuing on that theme, Mao, you highlighted some recent work around the methodological advancement. And so what are some challenges that you're thinking about as you select methods for these vaccine safety surveillance, both today and in the future?
Yes, thank you for your excellent question. I think the nature of this set of problems for vaccine safety surveillance are uniquely challenging. So first is that because the vaccines are often updated every year, the time for making decisions is very narrow. As you can see, Dr. Lloyd has had to give many presentations at many conferences over the last year, which goes to show how rapidly decisions and information must be generated to help support regulatory activities. So that's one item. Another item is the use of observational studies, observational data. We mainly use claims data supplemented by immunization information systems, as Dr. Gruber mentioned, and we do our best to try to capture as many exposures and outcomes as possible with minimal misclassification, but necessarily these are databases that were not constructed for the purpose of research and therefore have certain limitations that require elaborate adjustments, such as through chart review or through imputation, et cetera. So that's something that is often very challenging to do at great speed, although I think Dr. Lloyd has done an excellent job this season. And then I think the last item that I'd like to point out is the enormous number of outcomes, number of exposures that we're looking at. Dr. Lloyd's entire talk was about one exposure outcome pair. There are many other exposures that we also looked at, many other outcomes as well. And especially given a variable resource environment, resource-constrained environment, the need to rapidly winnow down to the most likely candidates for elevated risk, that's something that's very important. So those are the things that kind of go into some of the decision making for the 2020 planned 2025 surveillance.
Thank you. And building off of that, Joanne, can you talk about some of the exciting use cases and ongoing areas of study that we can look forward to hearing about next year?
Yes, thanks. Can you hear me okay? Great. Thanks for that question. I think there's a lot of exciting things to look forward to, and I think my colleagues have already talked about, the new methods we're using to generate rapid information, and we continue to just try to improve upon what we're doing, and that's something that's always exciting and that we like to present to this audience. We're also really excited to broaden into other areas that CBER regulated products, blood components, cell and gene therapies. And in the session this afternoon, as several of our colleagues will talk about, areas that we're going to develop. And I think some of those are really interesting use case, and cases that we'll present next year and that we're really excited about moving forward.
We do have a couple of questions from the audience. I'm going to talk about these as well. This is in reference to Dr. Lloyd's presentation. The audience member is curious whether you have any hypothesis as to why the PPVs appear different between the risk interval and the control interval.
Yeah, thank you. That's a great question. Before I answer, I realize that I didn't describe myself. So let me do that now. I am a woman with dark brown hair and I'm wearing a tan jacket. So I forgot to do that beforehand. In answer to the question, yes. So I think that we have considered possible reasons for seeing differences in the PPV and the risk interval and the control interval. One could be that if the clinician who is seeing the patient knows that the patient has received a vaccine very close to their diagnosis date or the date that they're seeing the patient, then they might be more likely to diagnose them as GBS, even if they haven't yet done as much testing as might be needed for that diagnosis. Whereas if the person that is diagnosed with that may be in the later part, so in the control interval, the 42 days to 90 days, if the clinician doesn't know that the person had received the vaccine and it is far away from when they received the vaccine, then they might do a little more testing to see what possibly is that true diagnosis. We're not sure if that's what it is. We don't really know. We're just trying to understand that as well because it is a big difference. And which is why in our analysis, when we're adjusting for PPV, we have taken into account when that has happened, whether it's in the risk interval and the control interval, and we're using those PPVs for the different intervals rather than just using the overall PPV.
Thank you. Really interesting. This is a question I think that I'm going to go to Yoon for this, but I think that the rest of y'all might have thoughts on this too. This audience member is asking about the idea that you're using Medicare fee-for-service claims data, which excludes, of course, older adults enrolled in Medicare Advantage. Given the expansion of Medicare Advantage to cover a larger share of the population, is there potential bias towards those who enroll in traditional Medicare fee-for-service as opposed to Medicare Advantage?
Yeah, well, thank you for that question. That's a great question. Actually, we also examined the time trend about people enrolled in fee-for-service versus Medicare Advantage. There is a very significant increase trend, the people enrolled in Medicare Advantage. We saw this transition over time. I think many years ago, probably Medicare Advantage only accounted for 5%, but now it's over half. I think earlier this year, it's like 33.9 million in Medicare Advantage, about 33.2 million in fee-for-service. So you can see that now Medicare Advantage is a majority. And in another study, these vaccine studies, actually we're looking at demographics and other characteristics, comparing Medicare Advantage versus fee-for-service. We were pleasantly surprised that actually they're quite similar. it's very reassuring. So for current study, we only use fever surveys, but at least for other studies, it's very reassuring that we got very similar result in other studies. Yeah, but I think that's a very good question. Because right now there are more people in Medicare Advantage, I think it's time for us to look into Medicare Advantage and use that data to inform our regulatory decision making. Thank you.
Thank you. All right. Well, I think that was all the audience questions. I do want to give you a chance if you have any last thoughts you want to add before we go. Oh, I do see an audience question right here. Do we have a microphone? We have a microphone coming for you, actually.
I'd like to elaborate a little bit on the issue of the difference in positive predictive value for GBS early after vaccination with subsequently during the control period. In this particular study, I understand that you evaluated days 8 to 42 as the risk period and 43 plus as the control period. But interestingly, days 0 to 7 were not included in either of the two periods. And if there is a bias in regard to GBS identification and reporting, is supposed to be higher on the first week because people are a little more alert on the first week. If you were to compare the rates of confirmed cases of GBS during the first week with the control week, you will probably see that they are similar, suggesting that even though the reporting of suspected GBS may be higher at the beginning, when you restrict the analysis to confirm GBS, you get the reassurance that that bias in, let's call it reported or suspected cases, does not stay, and you will have similar rates of confirmed GBS on week 1, when for an autoimmune disease, you should not find an association with the control period. Would that be a correct statement, or would you like to elaborate?
Yeah, I don't know if I could necessarily speak to that. We did not, we used a risk interval of 1 to 42 days and our control 43 to 90. We did not evaluate any of the smaller or other potential intervals that could be used. I think it's a great point. I'm not sure if others may want to comment, but I think that's something to consider. Yeah. Thank you for that comment.
Thank you. Yeah. Anyone else? All right. Well, this has been a fabulous panel. I've really enjoyed every second of it. Thank you so much. I really appreciate it. So if we could give our panelists one last hand, and then I will let you guys go to lunch. Be back at 1:40 sharp for afternoon sessions. Thank you so much.
All right. Thank you, everyone, for rejoining us after lunch. We're glad you're all here. It is now 1:40, and we will go ahead and begin with our next session, which is entitled Insights into the Future, Sentinel System 3.0. I'm Rachel Hendricks-Stirrup. I'm the Research Director of Real-World Evidence at the Duke-Margolis Institute for Health Policy at Duke University. So I introduced the title of this session, and I'll tell you more about it. So for this session, you'll hear from Sentinel System representatives and dive a little deeper into their work's current and future directions, which is really exciting. The speakers will highlight Sentinel System 3.0 and provide an overview of the goals and milestones for the new contract recompete. So first, we will begin with a presentation from both of our panelists, followed by a brief moderated discussion. Speaking of our panelists, I would like to introduce them. So first, we have Patricia Bright, who is the Associate Director of the Sentinel System Lead at the US FDA. And we also have Amaryllis Vega, who's the Director of the Regulatory Science Staff in the Office of Surveillance and Epidemiology at CDER, also within the FDA. I'll give a brief description of myself. I am a 5'5" medium complexion, brown hair, brown-eyed woman. For those who are visually impaired or challenged. And so now that I've gotten all of our introductions out of the way, I'll go ahead and pass it over to our panelists who will begin this session with their presentations. So Patrizia, feel free to start us right off.
Good afternoon and welcome back. My name is Trish Bright, and I'm the CEDAR Sentinel System Program Lead. I am a Caucasian woman with brown hair. My hair is in one braid over my left shoulder. I have on a navy blue blazer and a white shirt. And here's the disclaimer. I'll start by providing some background, and then I'm going to talk about 5 years' worth of work, mostly focused on the Innovation Center. Then we're going to be talking about the extension year, which is where we are now as of October, and how this informs our direction forward. So an independent assessment of CEDAR's Sentinel System was completed around 2017, and this was done to fulfill the Prescription Drug User Fee Act, or PDUFA 5. And in response to this assessment, CEDAR developed a strategic plan that informed the contract. So at that point, 2019, that was Sentinel 2.0, with a focus on improving Sentinel system capabilities to meet CEDAR's needs. So FDA established 3 centers to address the goals outlined in the Sentinel System 5-year strategy. And I'm mostly going to be talking about the Innovation Center, which is in the upper right. So the goal of the Innovation Center was to prioritize, develop, and incorporate innovative technologies and new data sources into the Sentinel system to help FDA achieve key legislative mandates and strategic priorities. There was a focused investment on innovations emerging from the new data science disciplines, such as natural language processing and machine learning, and to seek to expand access to the use of electronic health record, or EHR data. The idea was to create a more robust Sentinel system, a transformative, multi-purpose national data and scientific resource center for evidence generation. Now we're going to talk about the 5 years worth of work with the Innovation Center. So I'm going to start off here by saying back at that time, there were some concerns around the limitations with the Sentinel system. And there was a focus on the improving the inability to identify certain study populations of interest from the insurance claims, as well as the inability to identify certain outcomes of interest from the insurance claims data. So the Innovation Center targeted 4 categories of project areas to work on. 1, data infrastructure, 1, feature engineering, another, causal inference, and detection analytics. And the idea was to complete projects in this area to create a real-world evidence data enterprise. And as you heard earlier, this is a query-ready, quality-checked, distributed data network containing EHR data for at least 10 million lives with reusable analysis tools. So this is a slide that you saw earlier, and this is just a mapping of all those projects that were done during that 5-year period. Along the top, you'll see the years from 2020 through 2024. And on the left-hand side, you're going to see the categories that I just mentioned, the project areas, the data infrastructure, feature engineering, causal inference, detection analytics. There was something called the innovation incubator, and on the very bottom there, the use cases. And so this was a lot of work. And now we have an additional contract extension year, and this allows us to fold in the learnings from the development projects into an operational system. And during the Innovation Center presentation, they talked a lot about the use cases. That's the very bottom row. I'll touch on it too, because although these started in year 5, some of these are still ongoing. So now talk about this extension year that started in October. So the use case 1 was improving ARIA's efficiency. And due to the limitations inherent to claims data, the Sentinel's active risk identification and analysis, or ARIA system, is sometimes deemed insufficient to address a regulatory question of interest. And linking EHR and claims data, incorporating advanced methods, can overcome some of ARIA's current limitations. And aim 1 here is a mouthful, so I'm going to take it in a few pieces. It says, for health outcomes of interest for which ARIA analysis were previously determined to be insufficient. So what that means is a review team may have been doing some work, a health outcome came up that they wanted to know more about. They brought it to the epidemiologists at FDA. The FDA epidemiologists considered how the ARIA tools within the Sentinel system could address it. And at that time, they said, no, it's not sufficient to get what we need. And so as part of this AIM-1 project, they took all of those cases, went through them all, and then considered conducting a fitness for purpose analysis and assessing the likelihood of successful development of computed phenotyping by incorporating rich EHR data and data-driven modeling methods. I'm not going to talk more about this because this was in Sebastian's slides, but it is really interesting. So when those slides come out, you might want to go ahead and take a look at that. I'll spend a little bit more time on AIM-2, which was conducting a protocol-based pharmacoepidemiology analysis to evaluate the complexities encountered and propose solutions for typical claims-based ARIA analysis that will be handled by linked EHR claims data. So in this case, what we were trying to do is say, okay, well, let's take one of these cases where ARIA was insufficient, and let's give it a go. Let's see what we can do through a protocol-based assessment and try to incorporate the EHR data and see how well it works. And on the right-hand side there, you just see the protocol. And so I talk a little bit more about this on the next slide. So here it says in 2017, ARIA was determined to be insufficient to assess the risk of acute pancreatitis with use of SGLT2 inhibitors. And I was actually the reviewer who made this determination. So I was working as part of a review team as an epidemiologist at FDA. This question came up to us. I'm the one who went to the Sentinel system and tried to determine whether or not ARIA would be analysis, which is, again, a subset of tools within Sentinel, and decided that it was not sufficient, okay? This is no longer an active safety concern, but the data challenges are still relevant. The diagnosis codes were known to have a limited ability to identify acute pancreatitis with a positive predictive value of about 55 to 66%. And this raised concerns about misclassification. And the data source that we used was the Sentinel RWE Data Enterprise Commercial Network. And just as a reminder, Rishi pointed out that there was both a commercial network and a development network. So this one is taking place in the commercial network. And the approach was a cohort study using propensity score fine stratification for confounding adjustment. The outcome was acute pancreatitis, defined using a probabilistic phenotyping algorithm. And you can find that publication that's available now in the top right box. And then applying multiple implementation methods to analytically address missingness by key confounding variables. And you can find that publication as well. So the status here says results are anticipated by the end of 2024. But if you go back to Sebastian's slides, he gave you sort of the latest data on that. So that might be of interest to you. Then this is in here, this is use case 2. This is strengthening ARIA sufficiency analysis. So although ARIA analyses provided vital information to the FDA to aid in regulatory decision-making, often uncertainties remain due to lack of data availability in insurance claims for critical variables pertaining to the research question, such as residual confounding, lack of validated outcome algorithms. So the 5 aims, there's a lot in here. There were 5 aims. I'm not actually going to go through these because Sebastian did. When he was talking about the +5, these were the 5 that he was talking about. I will spend a little bit of time on AIM-4 just because, you've heard about this topic in general earlier today. It's just of interest to FDA. So AIM-4 is identifying use of cannabis-derived products, or CDP, from free text notes. So the context is there's an increasing interest in the potential utility of cannabis for a variety of medical conditions, as well as research on the potential adverse health effects from use of cannabis. FDA has not approved cannabis for the treatment of any diseases or conditions, but has approved Epidiolex, a cannabis-derived product, or CDP, in the form of cannabidiol, or CBD. We selected this as a use case. From a regulatory perspective, we weren't asked by a review team to assess whether Sentinel's ARIA system is sufficient to address CBD-related regulatory questions. However, there's an important public health value in better understanding use of these products. And despite increased patient usage of unapproved cannabis-derived products, in recent years, CDP is not currently captured in structured claims data. So the usage of cannabis-derived products may be recorded in unstructured patient-reported data EHRs. So our data source here was the Sentinel RWE Data Enterprise Development Network. So now this is the other network. And the approach was developing a method of capturing patient usage of CDP from linked EHR claims data and performing exploratory analysis to characterize patients using CDP. And there was an interest in identifying individuals with suspected CDP exposure in the structured EHR data. Also, using NLP tools and algorithms to find CDP exposure in text from clinical notes. And analyzing patient cohorts identified based on exposure to Epidiolex, CBT, and CDP to understand demographics, clinical and characteristics, and co-medications. So the results are expected in spring of 2025. But again, if you go back to Sebastian's slides, he did put in the latest data he had on all of these projects. So that might be of interest. So what else are we doing in this extension year? As part of our PDUFA 7 commitments, there is a section on enhancements and modernization of the FDA drug safety system. And under that, there's a section on optimizing of the Sentinel Initiative. And within that, there's an effort in pregnancy safety, and FDA will develop a framework describing how data from different types of post-market pregnancy safety studies might optimally be used. And so we have projects going on during this year. We're developing protocols for pregnancy safety demonstration projects to identify best study approaches to fill knowledge gaps. And beyond the pregnancy safety, we also have a project on negative controls. So during our extension year, we have a project underway to extend, test, and adapt an algorithm for disconnected negative controls to large-scale healthcare data. So how does all of this work inform our direction forward? What I have listed here are the publications from this year from the Innovation Center. There's also publications from the Operations Center, but this is just the Innovation Center, and it's just 2024. And I will point out that we're still in calendar year 2024, so more of these are coming out. And I want to bring this to your attention, how to find these. So I have in there where to look if you want to get some of these publications. So you can go to the sentinelinitiative.org website, and at that point it becomes sort of self-explanatory, but just look under the tab in News and Events, and then Documents, Presentations, and Publications. And you have the list here. And the idea is that we want these learnings not only to inform our work going forward, but we also think it's good for the field in general, and so that this might be of help to people. Additionally, there's webinars from the Innovation Center also on our website. So if you look, again, go to sentinelinitiative.org under News and Events, and this time go under Meeting, Workshops, and Trainings. You can find links to all of these recorded presentations, and this may be of help to people. So the next presentation will provide an overview of CDER's new Sentinel contract recompete, and that's going to be given by Dr. Lisi Vega. But before we get there, Rachel, did you have any clarifying questions for me, or do you want me to sit down? Or
Actually, I think we can quickly ask you a few questions before we turn it over to Amaryllis. So you mentioned that in the assessment of the Sentinel system, that this was completed in response to the PDUFA 5 commitments. And so I think I'm wondering, is an assessment of the Sentinel system required in each PDUFA commitment letter? Or is it distinct?
Yeah, well, it's somewhat distinct, but I would say in PDUFA 6 there was a requirement, and so we did do a report there. And you can find that if you go to, just go to a search engine and put in FDA, PDUFA 6, and CDER Sentinel assessment, and you'll be able to find it there and pull up that document. Now, I would say for PDUFA 7, we actually have a requirement that's due end of 2025 to report on analysis, reported analysis and metrics around the work that we're doing now. And so we're sort of actively collecting that as we go. So that should be available to people too, but we're working on it now. And PDUFA, I don't know what's going to be in that.
Sure. Yeah. And then I think one more question that
Sure.
that might be of interest to everyone here, really, and folks online. So you talked about a strategic plan for Sentinel 2.0
Yeah.
And how that started in 2019.
Yeah.
Do we expect to see something similar for the next contract?
Yeah. I'll say it's not clear at this point. Is Dr. Vega is going to show what the next, some thinking that's going on around the next one. And what we'll do first is we're going to launch that system. And it may be true that a strategic plan might help after we get through the launch and kind of thinking about how to coordinate how the work will roll out from there. But we have to sort of wait and get a little farther along, I think, to make that decision. But thank you for those questions.
Yes, of course. Yeah, and I think in the interest of time, we'll go ahead and move over to the next presentation. So thank you.
So good afternoon. My name is Amaryllis Vega, and I am the Director of the Regulatory Science Staff in the Office of Surveillance and Epidemiology. I am a Puerto Rican woman with short gray hair, eyeglasses, and a black suit. There we go. Now we can get started. All right, this is my disclaimer. And so the views expressed in this presentation are those are my own and not necessarily those of the Food and Drug Administration, but I think that they are pretty close. Just saying. So the FDA has a strong commitment, and CDER has a strong commitment to transparency. Thus, the inclusion of this presentation in this workshop is not your usual scientific presentation. So the goal of this presentation is to share with you some behind-the-scenes views of the Sentinel recompete framework and the next steps in the process. However, I have some good news and bad news for you. And the bad news first. Because of the sensitive nature of the procurement process, I will not be able to take questions from the audience today. However, we're very interested in your input. So the good news is that you will have the opportunity to send your questions, comments, and recommendations to FDA, and we will respond in a special notice that will be posted on sam.gov. I will provide, last slide of this presentation, will provide additional information on how to go about that and timelines, etc. Okay, so this is an overview of the Sentinel contracting cycles. They usually run in 5-year cycles. And to add some context, I'm including here the PDUFA cycles too. There are PDUFA commitments specific to Sentinel, as Trish already mentioned. The work related to some of those have informed and impacted the direction of the program. Please note that the PDUFA cycles and the Sentinel contracting cycles are not perfectly in alignment, which require sometimes that we do some contracting gymnastics to make things happen. So there are 4 contracting cycles supporting Sentinel, the Sentinel system, including the recompete. The first cycle supported the work of Mini Sentinel. The second cycle supported the transition from Mini Sentinel to Sentinel 1.0, which is the fully developed Sentinel system. In this phase, Sentinel was integrated into the regulatory review process. And just to add context, the CBER BEST was launched in 2017. We are currently in contract cycle number 3, or Sentinel 2.0. Please note that a PDUFA 5 required assessment informed the development of the 2019 5-year Sentinel strategy, as you heard before. The strategic plan has been implemented during Sentinel 2.0, as you have heard this morning, in the morning and this afternoon. In addition, there is a PDUFA 6 required assessment, which also provided information about areas for potential improvement, and Dr. Bright just referred to that. At the end of fiscal year 2025, there is another Sentinel assessment, which is a PDUFA 7 requirement. So Sentinel 2.0 has a robust scientific methods development component. The focus of Sentinel 3.0, however, is on the production of scientific evidence to support FDA regulatory work. One of the contracts supporting Sentinel 3.0 had an early start in 2024, and this is the Program Management Organization, or PMO contract. I'll talk more about that later. The Data Hub contract, which is the largest one in this ecosystem, will be awarded at the end of fiscal year 2025. So the recompete process was informed by input that we received from senior leadership in CDER, Sentinel users, and from the Office of Acquisitions and Grant Services. They oversee the contracting process in FDA. We're also leveraging the work that you have seen conducted under Sentinel 2.0. Also, FDA reached out to the public through 3 requests for information, or RFIs, and the slide will include links where you can access that additional information. So the Sentinel System 3.0 has 3 main goals: a narrower focus, broader access to data, and scalability to allow adjustments for budget variability. Sentinel 2.0 has an emphasis on capability building, while Sentinel 3.0 will focus on production. This is increased emphasis on generating scientific evidence to support our regulatory work. Sentinel 3.0 will expand access to multiple data sources and types of data with the objective of improving ARIA sufficiency and readiness to address public health emergencies. Sentinel 3.0 will implement a more flexible, multifaceted approach to access more granular data, advanced analytic methods to abstract data from medical records, and advanced statistical methods to conduct inferential studies. Sentinel 3.0 capabilities will be scalable, and you have heard that theme this morning, that to accommodate the funding variability that we experience from year to year. So funding is a big topic here. So there are 3 factors that we must consider to ensure the success of a scientific program: the funding, the staffing, and the contract vehicles. So there are budget realities, including the fact that the Sentinel operations rely completely on being appropriately funded. But for example, the data and associated services are expensive. ARIA is an unfunded mandate, but we acknowledge that FDA receives some congressional funding targeted to selected Sentinel projects. Also, there's variability in the funding available to support Sentinel each fiscal year. Another factor to consider is the program staffing. It requires many people to run all aspects of a complex program such as Sentinel. Here is the group of staff that runs the Sentinel program in OSC and in CDER. The executive sponsor of the Sentinel Initiative, Dr. Gerald Delpan, the CDER lead, Dr. Robert Ball, and Dr. Bright, who is the Sentinel program lead, and her team, including 7 epidemiologists led by Dr. Sarah Dutcher, the 4 members of the program management team led by Jamila Moidal, and 1 acquisition project manager. While many staff across CDER work on Sentinel, only Dr. Bright and her team are fully dedicated to support Sentinel's day-to-day activities. OSC manages the contract that supports Sentinel, And the current contract vehicle is an indefinite delivery, indefinite quantity, or IDIQ contract. And I know this is a technical terminology, but it will make sense when we talk more about the recompete. So more about that shortly. Sentinel 2.0 originally included 3 centers. However, during the extension year, which is running from September of 2024 through September of 2025, the Sentinel system will be operated by the Sentinel Operations Center by Harvard Pilgrim Healthcare. Sentinel 3.0 includes an expanded ecosystem supported by the FDA Sentinel Coordinating Center, 2 contracts, and an interagency agreement with the Centers of Medicare and Medicaid Services. So the Sentinel Coordinating Center, managed by Dr. Bright and team, will provide scientific and operational support and leadership. FDA is expanding its current interagency agreement with CMS to include Sentinel work. FDA has a long-standing relationship with CMS and collaboration. Through this interagency agreement, both agencies have the opportunity to work on scientific issues of mutual interest. The Data Hub is the largest contract, as I mentioned, in the Sentinel 3.0 ecosystem, and it would allow FDA access to multiple types of data and data analysis services. The Data Hub is supported by a multiple award IDIQ tier contract. The Program Management Organization, or PMO contract, is a single award IDIQ contract awarded to BizWest IT Solutions in September of 2024. The PMO will provide program and project management support to the Sentinel system, will manage the Sentinel Initiative website, and will create and maintain a secure portal to support all Sentinel 3.0 work. This secure collaboration portal is referred to as the collaboration platform. This is a graphic representation of the collaboration platform. The platform will allow the secure exchange of information for all collaborators within the Sentinel 3.0 ecosystem. The PMO will also support the Sentinel Initiative website and a public-facing source code repository. So what is an IDIQ contract? For those who are not familiar with this terminology, an indefinite quantity contract provides an indefinite quantity of supplies or services during a fixed period of time and are often referred to as task order contracts. This type of contract allows flexibility in both quantities and delivery schedule. An IDIQ is awarded to one or multiple contractors. Task orders under an IDIQ are awarded to contractors who have been awarded the IDIQ contract. So the Data Hub contract will be a multiple award IDIQ contract, including multiple tiers. This is an example of what we currently are thinking about the Data Hub structure. However, the official final requirements will be included in the solicitation, which will be officially posted in the spring of 2025. Each tier describes the types of data or services required by FDA. For example, Tier 1 in this example will include commercial healthcare insurance claims data. Tier 2 will include claims data aggregators. Tier 3, EHR data linked to claims. Tier 4, scientific support services. And please note that this tier does not require contractors bring their own data. Instead, Tier 4 contractors will support scientific work led by FDA in close collaboration with the CMS, the PMO, and other Data Hub contractors. Tier 5 includes specialty EHR data, for example, inpatient data, registry data, and data accessible via health information exchange systems. The circles on the left-hand side represent the contractors awarded the IDIQ tier. However, this is just an example, and the total number of awardees per tier has not been determined yet. So multiple vendors can compete for and may be awarded the IDIQ and task orders in one or more tiers. An individual vendor does not have to meet all the requirements for all the tiers to participate in this contract. So what are the advantages of this type of contracting approach? Well, it allows for increased diversity in the panel of participating contractors and the opportunity to calibrate the number of studies conducted in Sentinel each fiscal year based on the available budget. Also, this new contract structure will allow for the award, in addition to for the award of optional tasks, providing the flexibility for future program enhancements and responsiveness to public health emergencies. However, what are some of the limitations? Well, an important one to us is that Sentinel 3.0 represents an increase in the level of effort for FDA staff to the expansion of the number of organizations directly participating in the Sentinel 3.0 ecosystem. However, we believe that the challenges of this approach are outweighed by the increased flexibility that it would allow the scientific program. The FDA Amendments Act of 2007 required the system includes a minimum of 100 million lives. However, how will this requirement be fulfilled in Sentinel 3.0? Sentinel 2.0 required a single contractor provides access to at least 100 million lives. In Sentinel 3.0, this requirement will be achieved through the total number of lives contributed by the data sources available through the Data Hub and through the CMS interagency agreement. Sentinel 2.0 required the use of the Sentinel Common Data Model. Although vendors may propose the use of the Sentinel Common Data Model as part of their technical approach, the use of the Sentinel Common Data Model will not be required. FDA will consider other technical approaches, including the use of other common data models. So how will the safety questions be processed in Sentinel 3.0? First, the safety question will be routed to the Sentinel Coordinating Center to be triaged and tracked. The Sentinel Coordinating Center will have discussions about what's the suitable data sources and analytic methods, including in those discussions contractors from the Data Hub and CMS IAA. The Sentinel Coordinating Center staff will provide study oversight. The scientific contributors to these different studies will include the FDA staff, of course, Data Hub contractors, and the CMS IAA staff. The PMO contractor will provide project management support. So in summary, Sentinel 3.0 will leverage prior Sentinel scientific work and advances in data science and health informatics. It is designed to address CDER's scientific program needs and legal requirements. It will provide a scalable, more flexible, multifaceted approach to improve ARIA sufficiency. FDA is on track at this point to launch Sentinel 3.0 at the end of FY25. This recompete involves a very complex procurement process, and its implementation requires integration of its four main components, not an easy undertaking. Due to its complexity, we anticipated potential slowing down in the production during the transition period. So what are the next steps in the development of Sentinel 3.0? During FY25, the PMO contractor will stand up the Sentinel 3.0 operational infrastructure, including the collaboration platform. The request for proposals for the Data Hub contract will be posted in spring of 2025 with an anticipated award date of September of 2025. Finally, Dr. Bright and her team will continue working with all relevant groups in CEDAR to refine CEDAR's approach for using the new capabilities of Sentinel 3.0. And as promised, I'll not be taking questions from the audience, but your input is very important. So please send your questions and comments to the Sentinel System, contract specialist or contracting officer by November the 14th. And yes, please, if you want to take a picture of these, do so now. By 12 noon Eastern Standard Time. The responses to your questions will be included in a special notice that will be posted, as I said, in sam.gov. Thank you so much for listening to this presentation and for your interest in the upcoming Sentinel 3.0. Thank you.
Thank you so much. And without further ado, I'll be introducing the next panel, which is focused on best system innovations to anticipate. My colleague, Christina Silcox, will take it from here. Thank you all again.
Thank you so much, Rachel. As she mentioned, I'm Christina Silcox. I'm back. I'm still a average height white woman with dark brown hair wearing a red shirt. I did think about switching that up, but decided not to. I'm very excited to introduce our panel today. They're going to be talking about future-oriented insights from the BEST system, future vision and aspirations this time. So our panelists for this session are Marianne R. Spencer, a statistician and epidemiologist in the Office of Biostatistics and Pharmacovigilance at the Center for Biologics Evaluation and Research at the US FDA. Hussein Ezeldine, the Associate Director for Advanced Technologies in the Office of Biostatistics and Pharmacovigilance at the US FDA. Carla Zelaya, epidemiologist at the Center for Biologics Evaluation and Research at in the Office of Biostatistics and Pharmacovigilance at the US FDA. And once again, Joanna Gruber is going to be joining us, an epidemiologist at the Office of Biostatistics and Pharmacovigilance at the CBER Surveillance Program, also at the US FDA. She'll be joining us again, once again virtually for this panel. So please come on up.
Thank you.
Marianne, go ahead.
Sure, go ahead. I was just waiting for the slides. But good afternoon, everyone. I am Marianne Spencer. I am an Asian American female with dark hair wearing a gray suit, and it's my pleasure to be starting this session today. Still waiting on the slides. Okay, perfect. Is there a lag? Oh, okay. Sorry, there's a slight lag. Okay, so as let me start here with this is my disclaimer statement, noting that this presentation represents the views of myself as the author, and I have no conflicts to disclose. So this session focuses on the work of the Biologics Effectiveness and Safety Program, known as BEST. Dr. Gruber presented a similar slide earlier this morning on this, but my purpose for sharing this at this session is to serve as a primer and as a reminder of what CBER's mission, vision, and goals of the BEST initiative are. CBER's mission is to create and utilize an effective national post-marketing surveillance system for CBER's regulated products to provide data for evidence-based regulatory decision-making. There are a range of products that fall under CBER, or the Center for Biologic Evaluation and Research, ranging from vaccines, blood, human tissues, cellular products, cell and gene therapies, and xenoplantation products. The BEST initiative, which is part of the Sentinel Initiative fulfilling the 2007 FDA Amendments Act of Requirements, serves as a preeminent resource for evaluating biologic product safety and effectiveness. As part of this mission is to leverage high-quality data, analytics, innovation to enhance surveillance and real-world evidence generation. So one of the things that I wanted to highlight as part of this is when dealing with real-world evidence, there are several challenges. Real-world data generation is messy. There's unique needs and special considerations for subpopulations and groups at risk that we must consider, as well as small populations and that can limit our detection of adverse events and safety signals, for instance, for rare diseases and many advanced therapies. In addition to this, there are other unique challenges with real-world data evidence generation, including data quality concerns, in that data can be incomplete, inconsistent, and lack standards or standardization. This can limit our ability to integrate with data. There are data interoperability issues and considerations that we must consider for the flow of information. And also, when you're dealing with observational data, it is subject to biases, selection bias, information bias, recall bias, among other biases. With that, this session in particular is to highlight the innovative approaches of the BEST program, advancing biologic surveillance for informed regulatory decision-making. And so there will be 3 topics that we'll be discussing today, focusing on these bullets above here. So we'll be covering rare diseases, including cell and gene therapies, vaccines for the American public that will focus on special populations or the pregnant population. And we'll also cover artificial intelligence and data mining. And so I'm just going to give a very brief primer on these topics in the slides to follow. First is cell and gene therapies. And so cell and gene therapies are a rapidly growing field holding promise for treating some cancers and rare diseases. This is especially applicable for conditions that are severe, life-threatening, and pose unique challenges in healthcare. So for instance, a low disease prevalence can result in a limited number of promising therapies and investments for treating rare diseases. The next topic that will also be covered in this session, as I'd mentioned, will focus on a specific population for vaccines, being pregnant individuals. And there are approximately 5.5 million pregnancies each year in the United States. Half of pregnant individuals use at least one drug or biologic product to treat acute, chronic, and serious medical conditions. And as I'd mentioned, there are several challenges that are unique to obtaining real-world evidence to determine optimal post-approval study designs to ensure the safe use of products among pregnant individuals, which will be covered today. And the top slide is not showing, but the last topic is on artificial intelligence. Let me click through. Oh, okay. Artificial intelligence and data interoperability. Dr. Azzaldine will be covering this as I'm following this slide to talk about, but this is on real-world data. When you're dealing with a distributed data network, this can pose unique challenges for data quality and reporting. This can result, for instance, in inefficient reporting processes due to manual reporting and data redundancies, and as I'd mentioned earlier, data integration and interoperability due to different standards that can impede the ability to share data across various sources. This presentation will cover adverse event detection, which will allow for timely intervention to improve patient safety, monitor efficacy for biologic products, and also help minimize the future risk in a timely manner. And it'll also cover FHIR-based methods to improve automation and validation to improve data quality in the work. So without further ado, let me hand it over to Dr. Azzaldine, which will cover artificial intelligence.
Thank you so much, Marianne. My name is Hossein Azzaldine. I am a Middle Eastern, short height, black hair with glasses and a gray coat. Feels very weird to describe myself. So today I'll be speaking about pharmacovigilance and the intersection at the age of interoperability and artificial intelligence. Usually in this presentation, I speak a lot about what we've been doing. Might not have this opportunity today, but I will try to go very quickly over the work that we're doing and then speak about our future plans. So what you have here is a comparison between what happens now in the real world about clinical exposure and outcome and what we are thinking about and hoping to achieve in the future. On the left, you see here, you have mostly manual detection of adverse events. You have manual validation, and then, of course, you have manual reporting. In the future, we're hoping to see automated or semi-automated detection of adverse events using real-world data. And then, of course, semi-automated validation of these adverse events. And more importantly, semi-automated reporting, which will reduce the burden on the providers and the public as well. What you're seeing here, this is a roadmap of our work since we started in 2019. We started on a foundational data partner database. We were able to develop phenotypes and validate these phenotypes. We started putting together our prototype pipeline that we used, and I'll give you a quick overview of this pipeline. Next slide. After this, in 2021, we started thinking about operationalization of this model and how we can scale up from one or maybe two or maybe few sites or databases into a more national scale. So at this point, we, in collaboration with our contractors at this time, we decided to explore health exchange, information exchanges. So we started looking at how can we do this at scale. And at that time, if you recall back, this was the promise of the 21st Century Cures Act and how providers are going to have FHIR APIs mandated at their systems, so you can connect to these FHIR APIs and start pulling data from these endpoints. So we started interacting with eHealth Exchange, one of the largest health information exchanges in the US, and we started building with them the pilot platform on how we can leverage this public health use case in validation and maybe in the future as well, detection of adverse events using health information exchanges. In 2022, we're able to conduct a couple of pilot studies, one of them looking at data quality and timeliness. And then the second pilot study is looking at automated detection using computable phenotypes. What you're seeing here, this is a depiction of our pilot platform. On your right here, you see the pilot platform in this dotted boundary. And it has multiple components. It has a component that receives the data, and it runs data quality checks on it. And then it has another component we call phenotyping or detection. This is a component that runs computable phenotypes on the data that's received to flag relevant information and pieces of evidence there that might help a clinician or someone who's reviewing these cases to determine whether these are actual cases or not, and also determine other aspects like exposure and severity and different components of their validation process. And then you have, of course, the validation component. After you run this data, the phenotyping detection component on it, you present this data to a reviewer, and then they're able to go through the information, and then if they feel that this is a reportable case, they can generate an adverse event-like report, a VERS or a FIRST-like report that can be shared with our safety officers. This is the pipeline that we've developed over the years. On the left here, you have an interaction between our pipeline or our platform and eHealth Exchange Hub that acts as a point that connects us to all their member participants so we can send queries and then receive information related to adverse events. Or in other cases, if you are doing an automated or active detection. So what I'm showing you here, this is the first case of our pilot two pilot studies. The first one we call the pull use case, and it starts from the bottom left where we have a knowledge of an adverse event. So we know of a case that happened and we want to pull additional clinical data using eHealth Exchange. So we start by identification of an outcome or a case. Then we use our platform to reach out, connect to eHealth Exchange, query this outcome or patient. They take our query, they fan it out to their participant in the network. If there's a match, they respond back, and then they bundle this FHIR data, and then they send it back to us. And then at this point, it goes into our platform and goes through the different steps that I just described. So this was the first use case that we conducted. And the purpose of this one was to actually assess the feasibility of using HIEs, or health information exchanges, for public health purposes, because you can use them for many things. For us as an agency, we want to leverage this data source for public health use. The second use case that we explored as well is the push use case. And in this one, this is like the semi-automated detection or automated detection, depending on how the healthcare providers want to approach this. Here, it starts from the provider, not from the FDA. So they ingest computable phenotypes that we develop. They run them on their back end, on their electronic health records. And cases that are flagged, they push them to the eHealth Exchange hub, which transferred these cases to the FDA BEST platform. And then we are able to view these cases and review them. So these are the two use cases that we explored with eHealth Exchange in our pilot phase. Giving you an idea here about who was in our pilot studies. So in the pull use case, we had 11 private providers in our use case, covering close to 30 million lives across the US. And you can see here the geographical spread. And then, of course, we had our federal partner, the VHA, participated alongside with Cedars-Sinai in the push use case. Wanted to show you a little bit of our results. We were able to publish this paper on data quality and timeliness in July 2024. There's another paper coming out in a few days on the validation study for the automated detection. But what you're looking at here is across the 11 partners that we were able to receive adverse events data from them, you're able to assess here three aspects of data quality. You're able to look at completeness, which are the green lines. You're able to look at conformance, which are the brownish, and then plausibility, which is the magenta color. And you can see here on the left, these are the different data elements that when you look at an adverse event report, there are required elements that a provider or individual reporting on an adverse event need to provide this information. So this is looking at the mandatory or the required data elements, because there are other data elements that are optional or maybe nice to have within the form. But we are assessing here the required ones. And you can see here for the green lines, which are the completeness, you see more on the right. So more 100% completeness, which is a very good results that you take out from this graph. When you look at conformance, which is not very surprising, you start seeing things that are really in the middle a little bit, which is, this is a known challenge that conformance to standards is something that needs a lot of work. When we're actively working with our ONC and our data standards and interoperability community to help improve the use of standards in FHIR and in other common data models as well. And then, of course, plausibility. This is a very case-specific component of data quality, because what you might consider plausible for one adverse event might not be the case for another. But I think the message here is that data completeness is really promising for us to continue leveraging this data source. Semi-automated, we developed 3 tiers of computable phenotypes. A very simple one, claims comparable just using diagnostic codes. If you have access, you can make this a little bit more complex phenotype by including more structured data. from the electronic health records. And then if you have more advanced capabilities, you can actually start implementing NLP, natural language processing, to the notes, and you're able to rely on the unstructured fields as well to grab information. Here's the fun part. So what are the next steps? We are looking at expanding our automated use case. And to be able to do this, we are exploring the use of CQL. I know here I see some of our previous partners on this project. They are laughing because we've been saying this for a long time, where we are hoping to be able to expand the use of clinical quality language, which is CQL, as a mean to disseminate computable phenotypes and scale automated detection. So we develop phenotypes, share them with our partners through the eHealth Exchange. They can run this on their FHIR data repositories, and then they can send back the cases. So this is one of the exciting new steps that we are looking at. Everyone would be probably shocked if I didn't include LLMs in there. So we are exploring the use of LLMs within our boundaries. So we're relying on open source large language models to do these use cases. These are under development. They are not in place yet. We're exploring the use of large language models to ingest the data that we receive from from health information exchanges, to process this data, map it maybe to more familiar terminologies that our safety officers are familiar with, and then of course put the data in a format that's more familiar to them, presentable, and also easy to analyze afterwards. Then the other use case that we're also very excited about is, again, using large language models for case adjudication. One of the very expensive things that we encounter in our work is validation of our phenotypes. So we are exploring, can we use large language models to actually do this case adjudication or not? So this is the last use case that we're looking at. Just in summary, we are, as we seen, our pilot studies demonstrated that health information exchanges are very promising as a potential for public health use case. We are hoping to leverage clinical quality language for scaling automation of detection, and then of course the use of large language models for case processing and adjudication. Thank you.
Okay, good afternoon all. My name is Carla Zelaya, and I'm a Scottish female. I'm wearing dark pants and a light jacket. Today I'm going to discuss our recent CAR T-cell feasibility study. I will give a brief overview of CAR T-cell therapy and its indications. I will then discuss the different CAR T-cell therapies approved to date, their safety concerns, and the plans for conducting a safety study with claims data. Specifically, our work to assess the exposure of CAR T-cell therapy in claims data and our assessment of the outcomes of interest in claims data will be covered in this presentation. Historically, cancer treatment options have included surgery, chemotherapy, and radiation therapy. While these are still the mainstays of cancer treatment, new immunotherapies have emerged over the past 10 years. Chimeric antigen receptor, CAR, T-cell therapy is one such immunotherapy. CAR T-cell products are human gene therapy products. Patients' own T-cells are genetically modified to enable recognition of a desired target antigen for therapeutic purposes. Specifically, the patient's T-cells are extracted by drawing blood through a tube to an apheresis machine, which removes the white blood cells, including the T-cells, and sends the rest of the blood back to the patient. Then the CAR gene is inserted into the T-cells in the laboratory, and the millions of CAR T-cells are grown in the laboratory and then given to the patient by infusion. The CAR T-cells are able to bind to an antigen on the patient's cancer cells and kill them. So, CAR T-cell therapy is indicated for the treatment of refractory or relapsed blood cancers, including B-cell lymphoblastic leukemia and B-cell ALL, large B-cell lymphoma, mantle cell lymphoma, follicular lymphoma, and multiple myeloma. The majority of cancers for which CAR T-cell therapy is indicated are considered rare diseases by the Orphan Drug Act of 1983. On this slide, the 6 approved CAR T-cell therapies are listed. The first, Kymriah, was approved in August 2017 and is the only CAR T-cell therapy approved for use in children with refractory or relapsed B-cell lymphoblastic leukemia. The 2 most recent therapies at the bottom, Abecma and Carvykti, are used to treat refractory or relapsed multiple myeloma. In terms of the safety concerns of interest in this feasibility study, T-cell malignancies, including CAR-positive lymphoma in patients who had previously received treatment with CAR T-cell immunotherapies, have been reported to the FDA. The FDA reviewed these reports and, as a result, have updated the prescribing information for CAR T-cell products. However, it should be noted that the overall benefits of these products continue to outweigh the potential risks of approved uses. I also want to note that the FDA has determined that the risk of T-cell malignancies is applicable to all of the currently approved CAR T-cell immunotherapies, all 6, and therefore secondary malignancies have been added to all of the product labels. Given that much of the previous safety analysis on the matter has occurred in the FAERS database, one of the ways we're hoping to assess the safety of CAR T-cell therapies further is through safety studies using CMS and commercial claims databases, which are part of the BEST initiative. To conduct a safety study of CAR T-cell therapy in CMS and commercial claims data, we first need to determine if we can detect CAR T-cell product use, and then secondly, identify and evaluate the adverse events of interest, namely secondary malignancies following CAR T-cell therapy. The main best data sources we have selected for the feasibility study are the CMS Medicare Fee-for-Service and Medicare Advantage, and also the commercial claims databases, specifically Optum, the pre-adjudicated claims databases, the Carelon, IQVIA, and the CVS claims databases. Our first goal in the feasibility study was to determine whether CAR T-cell therapy, we could assess CAR T-cell therapy use in the CMS Medicare databases. To do this, we looked at persons aged 65 and older who had been continuously enrolled in their health plan for 365 days prior to CAR T-cell therapy, and we identified the treatment through the CPT and product-specific ICD-10 codes on the administrative claims from inpatient, outpatient, or other professional billing settings. We only looked at the first procedure observed for individuals during the study period, and those were counted as an exposure. In this process, we successfully identified 8,236 persons who, over the age of 65, who had been continuously enrolled for 360 days and had had CAR T-cell therapy. Among these persons, their demographic characteristics were examined. The majority were under 74 years of age, slightly higher proportion were male, and the majority are white, and the majority resided in urban areas. The next goal of the feasibility study, which we're still undergoing, is to identify and evaluate adverse events of interest in the BEST initiative claim databases. The adverse events of interest are secondary primary T-cell cancer, myelodysplastic syndrome, myelodysplastic syndrome, and acute myeloid leukemia. The only incident outcomes will be counted, and an incident outcome is identified as a diagnosis without another identical diagnosis in the prior 365 days. A patient is censored from a specific outcome after the occurrence of that outcome. However, each outcome of interest will be assessed separately, and therefore a patient can contribute to multiple cohorts. We are developing algorithms to identify these outcomes with various specifications to come to a conclusion on the best algorithm which reaches the desired specificity and sensitivity. The algorithms are being assessed and ranked by clinical plausibility based on a panel of experts, provider specialty plausibility. So we're going to assess the number of outcomes that are diagnosed by a provider specialty, by each provider specialty. The procedure report rate, and that means assessing the percentage diagnosed with an outcome who have an accompanying pathology or and biopsy procedure codes within a window of 90 days prior and 90 days after the outcome diagnosis date. We're also going to look at treatment report rate. So that assesses the percentage diagnosed with an outcome who have an accompanying treatment code within 90 days after the outcome diagnosis date. And then lastly, we're going to look at time from exposure to outcome to assess the percentage diagnosed with an outcome with an expected time between exposure to each outcome, which will be unique for each outcome. Okay, so some of our next steps is to ascertain our exposure cohort in the commercial claims databases, and then finalize the algorithms to identify the adverse events of interest in both databases. We're going to calculate the rates of these adverse events of interest in the exposure cohorts. And then lastly, which will be difficult, is to identify a control group, given the nature of the indication for these therapies. So that's the end of my slides, and I'm going to hand it over to the next speaker.
Thank you so much. And Joanne's going to be joining us online for the next portion of the talk. And Joanne, I'll be taking care of your slides.
Great. Can you hear me okay? Can you hear me?
Yes.
Okay, great. I just wanted to check. Thank you. Good afternoon. My name is Joanne Gruber. I am a white woman with long brown hair and a blue suit jacket. As was said earlier, I'm an epidemiologist in the Center for Biologics. Today, I will be speaking about the capabilities of the BEST system to study biologic safety in pregnancy and our planned studies. Next slide, please. Or actually, I don't see the slides. Are they up? Okay, great. Perfect. Thank you. Here's an outline of my presentation. I'll begin by discussing some background and the current PDUFA 7 commitment. Then I will touch on some of the capabilities we've developed in the BEST system to study biologic safety and pregnancy. And finally, I'll touch briefly on some of our current studies as we expand our portfolio to study the safety and effectiveness of biologics used in pregnancy. Next slide, please. So studying the safety of medical products used during pregnancy is important to ensure products are safe for the pregnant person, fetus, and infants. As many of you are probably aware, pregnant persons have historically been excluded from clinical trials of medical products, including many biologics. Therefore, post-approval studies are critical for generating human safety data in pregnancy and can inform drug labeling and patient care. Next slide, please. FDA has been involved in a number of efforts over the last several years to advance pregnancy safety data collection. Most recently, FDA has undertaken additional efforts to improve post-approval safety data collection as part of the Prescription Drug User Fee Amendments, or PDUFA 7 commitments. These commitments state that FDA will develop a framework describing how data from different types of post-marketing pregnancy safety studies might optimally be used, incorporating knowledge of how different types of post-market studies have been used by FDA and industry, and identifying gaps in knowledge needed to be filled by demonstration projects. CBER is participating in the development of the framework along with our colleagues at CDER, and BEST will be used to fulfill one of the demonstration projects, which I'll touch on briefly in a few slides. So in summary, post-approval safety data in pregnancy are important and a priority area for both FDA and CBER. Next slide, please. So in the next slide, I'll discuss the capabilities that have been developed in BEST to study safety of biologics in pregnancy. I will begin by discussing the work CBER did to validate claims-based algorithms to identify pregnancy outcomes in claims data. Next slide, please. So to conduct safety surveillance of biologics in pregnant people, BEST needed the capability to identify pregnancy outcomes using standard coding systems in the ICD-10 era and the ability to determine gestational age. Next slide. Therefore, we used the BEST system to develop claims-based algorithms to identify pregnancy outcomes, including live birth, stillbirth, and spontaneous abortion, and estimated gestational age through the most reliable evidence in the claims data. We then sampled identified pregnancy outcomes and claims and used structured EHR data and the global alignment of immunization safety assessment in pregnancy case definition to evaluate the performance of claims-based algorithms. We then estimated the percent agreement and corresponding 95% confidence interval between the claims identified outcomes and those outcomes meeting the global alignment of immunization safety assessment and pregnancy case definitions in the structured EHR data. Next slide, please. So we reviewed almost 300 records for this validation, and this study shows the percent agreement for each pregnancy outcome. The y-axis shows the pregnancy outcome, and the x-axis shows the percent agreement and corresponding 95% confidence interval. The number of records reviewed for each outcome is on the right of the figure. Overall, our claims-based algorithm performed well at identifying pregnancy outcomes with the percent agreement ranging from about 62 to 100%. And these algorithms did particularly well at identifying full-term live births and spontaneous abortions at 98% and 100% agreement, respectively. Next slide, please. So this panel figure shows the percent agreement for gestational age by our pregnancy outcomes. Again, the y-axis is the pregnancy outcome, and the x-axis shows the percent agreement by gestational age for the pregnancy outcome. So the left panel shows the percent agreement for gestational ages that were within 7 days of each other. And the right panel shows the percent agreement for gestational ages that were within 14 days of each other. So as you can see on the left panel, the claims-based algorithm for determining gestational age within 7 days of the referent method performed well with the percent agreement of about 61 to 86%. And this agreement was highest for full-term and preterm live births at 82 and 86% respectively. And moving to the right panel, you can see this level of agreement increased quite substantially when we assessed the agreement and allowed there to be 14 days between the method and the referent method. And that percent agreement was 80 to 99%, and full-term and preterm births had excellent agreement at 99 to 93% respectively. So next, I'll present the work that we've done to link mothers and infants in our claims database. Next slide, please. So to study pregnancy outcomes, linkage of mothers and infants is not required, but if we want to study the safety of biologics used in pregnancy and potential influence on infant health, BEST needs the capability to link pregnant individuals to infants. So we built this capability to link pregnant individuals with live deliveries to live-born infants in our administrative claims databases. Next slide, please. So to complete the linkage, we started in our claims databases from Carelon Research, CVS Health, and Optum. These are our commercial insurance databases who are partners in the BEST initiative. And first, we identified females aged 12 to 55 years of age who had a live delivery. And then next, we identified live-born infants that had a known date of birth. And then we linked the live deliveries to live-born infants. And to do this, we used the infant and mother's insurance subscriber ID. And the subscriber ID identifies the person or group of people on a given insurance plan, and individuals with the same subscriber ID are covered under the same plan, and in most cases are part of the same family. We also required that the mother's delivery date and the infant birth date be matched, and we did exact matches and also allowed there to be a window of 3 and 7 days between those dates. And then finally, we estimated the linkage rates as the percent of live deliveries that link to live-born infants. Next slide, please. So we identified over 2 million live deliveries with that number varying by database. And this figure shows the linkage rates between the live deliveries and the link to live-born infants. And the y-axis, we have the percent, and the x-axis, we have the window that we allowed between the delivery and infant birth dates, with those having to occur on the same day, within 3 days, and within 7 days. And the colors represent each data source. So as you can see, we had good linkage rates between the deliveries and live-born infants, and rates were 41 to 48% when we required an exact match between the delivery and the infant birth date. And that improved quite dramatically when we allowed there to be that 3-day window between those dates. that ranged from 70 to 81%, but didn't improve a lot when we allowed that range to be within 7 days at 71 to 82%. Next slide, please. So in the last few slides, I'll wrap my presentation up by describing some examples of studies that are underway. And these studies highlight some of our efforts to, again, improve our capabilities and do additional work to understand biologic safety in pregnancy. Next slide, please. So as I mentioned earlier, we are conducting a PDUFA 7 demonstration project, and our current project will focus on improving algorithms for identifying preterm birth in claims databases. So although we have an algorithm that can identify preterm birth, in our prior work, we found gestational age was underestimated. And so that resulted in the prevalence of preterm birth of about 12.3%, and that's compared to about 10% for the national average. So we know that there are issues with the misclassification. So in this work, we'll focus on, in this work, we found that small differences in gestational age, even though they were very close to one another, could result in large amounts of misclassification. 35 of 93 preterm births were actually full term, and 23 of those had a difference of only 1 week's gestation. So we see this issue with the claims databases. We have to have exact precision here to get this right. So this motivated us to explore additional ways to improve the positive predictive value of a claims-based algorithm for preterm birth to ensure we identify true preterm births for our studies. And that's what we'll do for our PDUFA demonstration project. Next slide, please. We are also working on an RSV a safety study in pregnancy. So one of the respiratory syncytial vaccines, or RSV vaccines, is approved for use in pregnant persons in the US to prevent RSV-associated lower respiratory tract infection in infants from birth through 6 months of age. And that is the bivalent RSV prefusion F, or RSV pre-F protein-based vaccine by Pfizer that was approved August 21st, 2023. And CDC recommends RSV vaccine for pregnant persons at 32 to 36 weeks of gestation. And that should happen seasonally based on the RSV season from September to January in most of the US. Next slide, please. Pre-licensure clinical trial identified imbalances in rates of preterm birth following vaccination compared to placebo. So in our study that we're currently developing, we're planning the study to evaluate safety outcomes, including preterm birth following RSV vaccination and pregnancy. Next slide, please. So in summary, CBER has developed several capabilities within BEST to study the safety of biologics in pregnancy. And BEST continues to develop capabilities and expand safety work to improve our understanding of safety of biologics used in pregnancy. Thank you.
This has been a fabulous session again. I've been really lucky with my moderations. Unfortunately, we have run out of time. We're running a little bit late, so we're going to go directly to break. For those of you who are in the room, I'm sure that our panelists would be happy to answer any questions. Thank you very much. We'll be back, starting back up again at 3:15.
Welcome back, everyone. I'm Trevin Locke, an assistant research director at Duke-Margolis. Pleased to be moderating the last session of our day at the 16th Annual Sentinel Initiative Public Workshop. During this session, we're going to hear from a wide array of perspectives about the Sentinel Initiative, including international regulators, registries, consulting, academia, industry, and of course, FDA regulators. We have a fantastic panel for the session. I'll introduce them now and we'll get in. First, Patrizia Cavazzoni, head of World Evidence Workstream at the European Medicines Agency, who should be popping up on the screen behind us. Mary Beth Ritchie, the Chief Scientific Officer of Sarab's Consulting, Associate Research Professor at Rutgers University, and the current President of ISPI. Frederick Resnick, Chairman of the Division of Cardiovascular Medicine at Leahy Hospital and Medical Center, and a Professor of Medicine at the University of Massachusetts School of Medicine. Andrew Bate, Vice President and Head of Safety, Innovation, and Analytics at GSK. And additionally, we're joined by a couple of folks from FDA, including Robert Baum, the Deputy Director of the Office of Surveillance and Epidemiology at the Center for Drug and Evaluation Research at FDA, as well as Richard Forshee, Deputy Director of the Office of Biostatistics and Pharmacovigilance in the Center for Biologics Evaluations and Research at the FDA. So we're going to start with some initial panelist remarks kind of down the line here. and then use the remainder of our time for moderated discussion and Q&A. Patrice, we're going to kick things off with you. I'm hoping you can hear us.
Yes, I can hear you very well. So hope it's the case also from your side, right? So I will try to give you very shortly a little bit of information regarding what we could call a little bit like a European Sentinel network. So it's called Darwin EU, Darwin for Data Analysis and Real-World Interrogation Network. And what we've built over the last 3 years now, it's really a federated network of data, expertise, and services that help the European Medicines Agency to go into a better decision-making process throughout the product life cycle, as I will try to explain shortly, by generating and delivering what we call valid and reliable evidence from the real-world healthcare data. It's a federated network, which is coordinated by the Erasmus Medical Center in Rotterdam, based in the Netherlands. And the point is that the EMA is connecting with the different committees that we work with, as well as other stakeholders. And we collect the data, the research question that will be of interest to address via real-world evidence. We assess this, we send the request to the coordinating center, and the coordinating center is connected to a panel of data partners, of data permit authorities. And if we observe that the study is feasible, then the study is done with a selected number of data partners. It's a multi-database studies most of the time, and the result is centralized by the coordinating center and sent back to us and back to the requester. In fact, the data stays local. It's the same principle as Sentinel. I think we do not have access as the EMA to the data, and we use a common data model, which is the OMOP common data model in order to perform studies in a timely manner, I will say, and also to increase the consistency amongst the different results. What we do with this, it's maybe a little bit broader than what the Sentinel is doing, because we for sure not only focus on safety aspect, but safety is one of the key activity linked to Darwin EU. We also looked at effectiveness, comparative effectiveness studies. This morning was mentioned also this regarding vaccine studies. We do also a lot, not only for vaccines, but also for other types of medicines. We looked also at the impact of regulatory actions, and that's what we call investigation of association and impact. We also looked at an understanding of the clinical context. So that's what I will say, the basic disease epidemiological studies, looking also on how patients are managed, and also on drug utilization studies. And we also look at how we can support the planning and validity of the studies that may be requested by the different committees to marketing authorization holders, and as well as also the representativeness, for example, and the validity of studies which are completed by MAH. So we work with multiple committees here within the agency. We can help in the orphan designation by, for example, generating prevalence data to support the orphan designations. We work also with what we call the Scientific Advice Working Party, the SWOP, by also looking at how we can support the discussion by using real-world data and real-world evidence. We work with the Pediatric Committee, for sure, to help to identify the needs in children and adolescents, to support also the discussion regarding the pediatric investigation plans. We worked also on the approval of drugs with the Committee of Human Medicinal Product, the CHMP. And for sure, we worked also a lot with the PRAC, so the committee in charge of the safety in the post-authorization phase. If I could give you some examples of studies that have been done or are ongoing, it's very diverse. It goes from a natural history of dermatomyositis, for example, in adult and pediatric population, treatment patterns of drugs used also in adult and pediatric population with lupus, drug utilization study of opioids. We have looked also at characterization of patients and diagnosed with multiple myeloma, treatment and survival of this patient. We had also a study on the use of antiviral for the treatment of chronic hepatitis B and C, the use of polypharmacy among adults aged 65 and above with cancer at the time of diagnosis. We looked at monitoring of prescriptions for essential medicines administered in ICU. So many studies indeed based on the use cases that I've explained. We do multi-database studies. I think it's obvious to all of you. It's the same principles as what you do also in the US, because indeed none of the real-world data sources capture, at least in the EU setting, all the clinical events equally well. So that's why we need to increase the breadth and the depth of the information. We also have as a target to have a quite good EU representativeness. So this is why we are looking at different countries, because it's important to inform well the decisions. By increasing the size also of the study population, we facilitate the research on rare events, on rare medicines, rare diseases in specific settings, for example, and enables subgroup analysis. And we also use these multi-database studies to really explore the heterogeneity of treatment options within the EU setting, also the heterogeneity linked of the outcome, the event rates across the different countries or regions. And that's something which is also very important for us to assess. When I was mentioning multi-database studies, it means like like in the US, for sure, we have access to a certain number of data partners, as I said. So we have currently data partners in Portugal, Spain, France, the UK, Belgium, Netherlands, Germany, Croatia, Hungary, Denmark, Estonia, Finland, and Norway. So it's within these 13 countries, we have 20 data partners, and we will most probably in 2 months from now release information regarding the 10 additional data partners that we have onboarded over this year. And the plan is definitely to have 10 more next year. And when I mention this data partner, it's really a mix of data type, I will say. We may have national registries, like in Norway, we have hospital, or Denmark, we have hospital data. In France, in Finland, we have biobanks. In Estonia and the UK, we have cancer registry. In the Netherlands and Norway, we have claims data. In Germany and Hungary, we have EHR data. In Spain, Portugal, France, UK, and so on. So it's really a mixed of setting. And that's something which is very important for us, because our objective, when I was saying we will soon release the name of the 10 new data partners onboarded this year, but we will have 10 more for next year. We really have in mind to have a geographical expansion. We have still big countries in the EU which are not part of the network, and we're working on it, like Italy, Poland, Sweden. We also looked at an expansion in terms of data types. We are looking at specialty registries, specifically on oncology, because we have there is a lot of oncology drugs which are under the pipelines from the pharma industry. We looked at having also biomarkers information, OTC information, medical device information, and so on, something which is a little bit missing currently within the current network. And we also have in mind, when we think about expansion, about undercovered population like neonates, pediatric population, pregnant women, and so on. Another point to mention is that for the onboarding, we have definitely I would say thorough check about the data quality of the sources. We have more than 600 checks which are done to assess the reliability of the data, the extensiveness, the coherence, the timeliness. So pretty aligned with the data quality framework that has been released 2 years ago by the European Medicines Agency. And when we start doing a study, we for sure looked at the relevance of the different data partners, and we select the data partners for a specific study based on indeed the reliability, which should be a given indeed, because these checks have been done at the time of the onboarding, but also for sure the relevance of the data and what we will call the fitness for purpose based on the user's needs.
Thanks so much, Patrice. Great to have your perspective, and know it's probably pretty late for you, so I appreciate you taking the time to join us today. Next, we're going to go over to Mary Beth.
Hello, I'm Mary Beth Ritchie. I have a fair skin type, brown hair, green top, black trousers, and I'm wearing these green shoes that are have a grippy bottom very specifically so that I don't fall, given a vertigo condition that I've had for about 20 years. So for me, Sentinel has been a really interesting process. About 15 years ago, I was reminded this morning I was the Center for Devices point of contact as we were putting together our first prioritization around health outcomes of interest. And so I used to be very, very involved in Sentinel. And now I see Sentinel once a year at these meetings. And so I wanted to start by saying kudos to the 5 slides worth of people who are actively engaged in Sentinel day to day that Darren presented earlier, and to all of the hundreds of others who have made this a possibility. It is absolutely wonderful to see where this has come in just a short time. Day in and day out these days, I do have the opportunity as the president of the International Society of Pharmacoepidemiology to see what's going on with different data around the world. And last month, I got to go to the Asian conference and see what is happening there. Within their data systems, they've been working for 15 years in order to be able to adequately understand and compare and utilize data from Japan and with Taiwan, with Korea, with mainland China, in order to be able to understand what's going on in multiple Asian contexts. And I think as we are looking forward to future opportunities, being able to really harness the different types of healthcare systems that are occurring in the United States and be able to utilize that differentiation between healthcare systems would be meaningful for us as well. And so the first thing that I'd like to do in thinking about the future is echo that thinking about the data we need and talking to ONC is critical because they will be able to say this is what is going into the data, and therefore we'll be able to look at those different measures for the different healthcare systems. And then I want to highlight that healthcare interactions are not the only place where people are dealing with their health. We heard earlier today that Medicare Advantage, the number of people there is increasing over fee-for-service. But we're also seeing that over time, people are moving to telehealth. And in the Center for Devices, they have an initiative about the home as a hub of healthcare. And so as we are needing to look to new data sources for Sentinel, I would encourage us to think about focusing on data sources that are going to be able to tackle that next phase of healthcare in the United States. In particular, thinking about how we can incorporate wearables, digital health, and other device data, as well as behaviors that may not necessarily show up in healthcare, like my grippy shoes. I think that there's not just that context of care, but a context of the different needs that need to be taken into account. We need to understand that this data from claims, EHR, and other kind of efforts is on the back of an access to care that is differential across the United States. We know that people in rural areas are coming to healthcare sicker about 45% of the time compared to those in urban settings. We know that our measures of race that are in claims and EHR are not adequate to understand what is going on for various proxies for which race and ethnicity are there. And then we know that the severity of condition at the time of interaction really does play into the health outcomes that people are seeing. And so we also want to be able to start over the next few years to be able to compare not just drug versus drug, not just biologic versus biologic, or a person at one time versus another time, but really be able to capture that context in which a patient is thinking about their care, whether that be today choosing between a drug and device, or tomorrow choosing between whether to stop line 1 of a treatment and move to line 2, and be able to help them understand how to traverse healthcare well. And then I think there's also a context of contribution. I've noticed today that we've talked a lot about patient centricity, and there's been no patient here talking about what's going on within Sentinel. And so I think that there is a need for us as we are moving forward to think about how to better integrate patients into the discussions that we're having around their public health as it is related to medical products. And then last but not least, I think that there's a need to include industry in the decision making as well. They are the ones who are taking on PMRs when it's not available for Sentinel to be conducting studies. They're the ones who are needing to assure over and over that the products that they have are safe and effective. And so I think that it's important to have them at the table as we move forward within Sentinel as well. So those are the future opportunities of context that I think we need to keep in mind.
Thanks so much. You also reminded me that I forgot my description. A white man with glasses in a great suit with reddish brown hair and beard. Next up, we're going to go to Frederick.
Hi, yeah. So I am I would say upper middle-aged white man whose hair used to be really, really dark, but right now is not as dark. I am wearing a blue jacket. All right, so besides that description, I'm actually a practicing interventional cardiologist. And I practice outside of Boston, having sort of lived my professional life in the Boston academic environment, currently at Leahy Hospital, where I'm the chair of cardiovascular medicine. Cardiology, as folks know, has kind of an outsized role, both in medications and spectacular improvements in outcomes because of the medications that have been developed, and but also in medical devices, which is actually the area that I've focused on throughout my career in looking at the post-market safety and performance of medical devices. And I've been very privileged to work with some of the folks at CDRH, including Danica, who was on one of the earliest panels of the day. And I think she mentioned how challenging working with medical devices are, because unlike the NDC, which becomes the sort of key for finding and identifying what the exposure was for drugs, the UDI, though certainly mature, is not yet mandated by CMS to travel through the claims, and without that motivation, there has to be other factors that lead to the capture and the sort of propagation of accurate UDI. So to know what patient was exposed to what device is actually still quite a trick and a challenge. So my work has been a lot around using clinical registries, and we're sort of fortunate in cardiology that we have a lot of really mature, nationally representative registries. And for implantable medical devices, registries make a lot of sense, as they sort of do for vaccines, right? Because it's usually, for an implanted device, a moment in time, that moment of exposure, and then the subsequent longitudinal follow-up that makes great sense. But there also are probably significant under-leveraged opportunities for bringing registries more into the Sentinel ecosystem. Registries have a certain advantage, especially the huge national registries in many subspecialties. First of all, they're very well connected to the clinician communities and the patient communities. They have very detailed, granular data about the clinical care, and because of the enormous costs, the costs are borne throughout the episode of care. They're actually highly refined, very high quality, granular data sources, and may complement some of the many enormous data sources that Sentinel does leverage today. I've worked with national registries in cardiology, in orthopedics, in vascular surgery, in cardiac surgery, some of which have nearly 100% coverage of the treated patient population through CMS requirements for participation in registries for very large procedures like transcatheter aortic valve replacement is mandated 100% of the time in the United States. If you want to get paid, you got to submit your data to a registry. There's only one registry. And so there are advantages in having that opportunity to work with registries, but I think there's unmet opportunities to leverage that for the the medication treatments, the pharmaceutical treatments that are also captured in these not only episodes of care, but the longitudinal care capture that happens. I've worked a great deal in active surveillance for medical devices, and it's actually just a wonderful opportunity to hear sort of how much progress has been made within Sentinel, and also how much there's been parallel play going on between what we try to do on the medical device side and the very mature work that's been done in Sentinel. We have an opportunity with registries also to think of near real-time surveillance as a new product is introduced into the market. Registries tend to have their the data being updated almost on a daily basis and can be reflected even in how we do the surveillance under that environment. We've had some interesting opportunities to answer some questions that I think is probably an under-recognized opportunity. I saw the Sentinel team talking about this, but the refutation analysis, when a concern has been raised and a putative safety signal was identified, to be able to go to high-quality real-world data like in a registry and relatively quickly determine that there is no evidence of an adverse event associated with the exposure to this device, I think can help our regulator partners a great deal. We've done that, and the paclitaxel is actually, it's a chemotherapeutic agent, but it's embedded on certain stents and balloons, and there was a significant concern from some meta-analysis that it was associated with a signal of mortality for patients who were treated with those devices in the peripheral arterial system, and it turns out that there is no evidence of that association in looking at really robust real-world evidence and the more recent clinical prospective trials. Like what has been learned in Sentinel, we're learning a lot about how to leverage EHR data, and somewhere sitting between, I would say, claims and the registry data, there's such a rich detail of granular information that we can get now with some of the tools that Sentinel has been exploring in natural language processing to extract the non-structured data out of EHR, even for device exposure, has been very helpful. So thinking ahead in terms of lessons, well, I certainly think that registries are an opportunity for Sentinel to further expand the portfolio. We heard about it from the European Medicine Regulatory Society that it's a complementary data source for them. And I think that can benefit all stakeholders. I also think that we get into some very complicated combination products. I mentioned the paclitaxel coated stent. It's actually regulated under CDRH, but the exposure is to a pretty, the signal of mortality that was of a concern was not about the stent. It was about the paclitaxel exposure and the duration of exposure from these devices. And so there are, I think, ever increasing complexity of devices, or, for example, drug delivery systems that are regulated through CDRH, but the drug is a drug, right? Or fully integrated, feedback loop systems, the artificial pancreas concept and things like that. I think that there are going to be enormous opportunities to learn across the different centers in CDRH of how we can collaborate. I do think that there's a challenge, and maybe Sentinel, as being such an enormous and successful enterprise, can start thinking about this. If there is value in leveraging registries, which I believe there is for the mission of Sentinel, CEDAR and others, the registry data owners are challenging just like clinical data owners. And their motivations for collecting this data, in fact, they're organizing policies and regulations under what laws they're actually formed and what the relationship is with the submitting organization. It can get very complicated, and I think that Sentinel and FDA and all of HHS should be congratulated on the leveraging of the public health authority for Sentinel's activities, because that would help a great deal in leveraging what are enormous opportunities in registries. Speaking even beyond registries for a moment to some of the contribution that MD EpiNet has made over the last 15 years, that was the organization that actually Denisha helped form, and there's been a lot of multi-stakeholder involvement. the notion of having a coordinated registry networks where US and international registries harmonize their data and allow for distributed queries to answer pressing questions is another opportunity, I think, as Sentinel looks for its next generation. At any rate, just to summarize, I think it's just an unbelievable story that Sentinel has been able to tell. And I think it's very exciting to think about the next generation of Sentinel, where I saw that row 5 in the proposal was to include registry. So I congratulate you on that.
Thanks so much, Frederick. We're going to go to next Andrew. I believe he has a couple slides.
Okay. Thank you very much. I'm Andrew Bate. I'm a white, middle-aged male with brown hair wearing a blue suit. I'm an employee of GSK, and I'm based in the UK. Prior to that, though, I was employed by a US manufacturer in the pharmaceutical industry here in the US. And before that, I worked for a World Health Organization collaborating center in Sweden for more than a decade. So my comments will be based on those experiences and 25 years in safety signal detection and real-world evidence generation. I think in this era, where opinions can be espoused and rapidly propagated, data-driven science has arguably never been more important, and I think Sentinel plays a key role in that. I think in looking forwards, we have to look backwards, and from the lens of 2024, I think it's easy to underestimate how transformative a capability Sentinel was at its launch and has been as a routine regulatory capability of real-world data, real-world evidence generation. Nevertheless, in looking forwards, we must not rest on the laurels and our successes of the past. And in terms of the myriad of future possibilities, where might Sentinel focus most moving forwards? And I just have a couple of slides I wanted to share. And I think the first point is to make that, and this has been said already, patient centricity must remain central to everything we do. The benefit risk of medicines and vaccines and patient safety must be at the core of how we advance. Some elements, though, that I think we must keep in mind. We must strive to be ever more effective in reducing duplicative work. So, for example, if FDA has done an analysis and industry only has access to the same data sources, what's the value of asking industry to replicate a data study in the same data sources? Instead, I think we really need to think as we move forwards about where will further studies really advance evidence generation in terms of our understanding of issues. In striving, in terms of trusted, consistent data and analysis, I think we need to be cognizant of the fact that while we often do use the same data sources, we have different stakeholders have access to different data records or different fields on the records or timeliness of access to the data sources. All of these can lead to discordant results, and I think that's damaging from a credibility perspective. I know there are reasons for these different data accesses, but I think we need to work together as stakeholders to try and get to a place where we can be more consistent in the analysis we do. Access for best insights for all. We've heard about it today. Rich data leads to rich insights, and I think we need to all work together to make sure we have access to the best possible data. And then impact and communication. Communication. I think from an industry perspective, awareness of what studies are planned, opportunities to provide inputs into that are timely and appropriate and transparent into study design, leveraging our expertise as drug and vaccine developers is important. And then back to patients. Patients and healthcare professionals deserve clarity on how fantastic solutions like Sentinel are being used to advance, as part of an ecosystem, their health and benefit risk understanding of medicines and vaccines. I wanted to just briefly speak about signal identification. And this is a slide I used now 15 years ago. It's identical in all apart from the fact that we see wider use of AI across the board, and that's the only change from when I first used this. And the reason I wanted to share this slide is, as we've heard all day, it's a routine capability to analyze real-world data for pharmacoepi studies and signal refinement, but signal identification remains an emerging capability. And I just wanted to touch on why I think that is. The first thing is, and ICSR's, individual case safety reports, were mentioned earlier. I think they're a fantastic source of a hypothesis generation, and we need to be cognizant of that, and that we actually do safety signal detection really well, and it may be challenging for real-world data sometimes to compete in terms of early signal identification. Secondly, we've heard about the imperfections of real-world data throughout the data. I think that's really important in safety signal detection, particularly our ability in the very rare and early to identifying clusters of patients having similar attributes and the lack of clinical suspicion often that resides in our medical records. And then I think there are some opportunities in terms of method improvements. Really briefly, what could we do differently to advance signal identification? Well, I think effective confounder adjustment is really challenging in signal detection because of the limited knowledge we have at the early phases of emerging safety issues. I think similarly, controlling for chance findings is really challenging when we know so little about things, and I think bias is more of a problem than chance findings. I think we need more intelligent clustering of exposures and outcomes to find similar records, not just relying on hierarchical terminologies. Semi-automated approaches for finding temporal correlations between exposures and outcomes. Outcomes of focus, maybe we should focus really on the outcomes that are less well captured in other data sources and are well captured in systems like Sentinel. And then I think maybe we should think about the range of data sources, and rather than doing analysis across all of the data partners, we could do subgroups of data and use that as a way of identifying and orthogonally challenging our findings from parts of a data network. So I think there's opportunities there. So just to conclude, I think signal identification is an area of challenge, where as a field we really need to collaborate together to make the necessary advances. There have been many successes of Sentinel. In the future, I believe there's great value in reducing duplicate or overlapping activities and focusing on even more on the data-driven evidence for the greatest impact in understanding benefit risk and protecting patient safety. Thank you for your time.
Thanks so much, Andrew. I think a lot of good ideas coming out already. I'll use this point as a reminder for the audience to put your questions into Slido. While you're thinking about that, we're going to turn to our FDA participants to see if anything has jumped out to you already that you might want to comment on.
Yeah, sure. My name is Bob Ball. I'm an older white man with limited brown hair and a beard, glasses, and a blue suit. So I think what I hear in the discussion here is very similar to I think what was presented earlier in the day. You know, more and better data in particular, better ways to analyze the data, patient centricity, expanding from signal evaluation to signal identification, and do that in a more complete way. So I think it's good to kind of see that there's common ground. You know, as was mentioned by several of the speakers, beginning with Dr. Cavazzoni this morning, I think the biggest challenge that FDA faces is the resources to do all this. Data is expensive, as is the analysts who have to do all this work. And so as we go forward, I think it's going to be challenging to figure out exactly how to pick the priorities for where FDA puts its resources for Sentinel 3.0. But I do feel, in a general sense, that there is a lot of commonality. So that's good to hear.
Rich, anything to add?
Yes. So, hi, everyone. My name's Rich Forshee. I'm a white male. My wife says my hair color is distinguished. All my IDs say it's gray. I've got short hair and a trimmed beard. I'm wearing a blue suit with a yellow tie and pocket square. First I want to say this has really been a wonderful day. I think we've had a lot of really great presentations that have covered a lot of the good work that's going on at Sentinel and BEST, and so I appreciate all the work that the organizers and the speakers put in to do this. I'd like to pick up on a couple of things that Andrew mentioned in his presentation. My work is in both the areas of real-world evidence and benefit risk assessment, particularly quantitative benefit risk assessment. And being in both those worlds has shown me how much they rely on one another, how closely linked they are. So the kinds of real-world evidence studies that we're talking about here are often critical in order to be able to conduct a proper benefit risk assessment. There are many times in our Center for Biologics Evaluation and Research where the inputs that we need for a critical benefit risk assessment aren't available when we start. And we need to turn to all of our partners within BEST, quickly develop a protocol and generate the results that we need to inform that benefit risk assessment to make the regulatory decision. So I just wanted to pick up on Andrew's point there and emphasize that these are not separate domains. It's a real important link between real-world evidence and benefit risk assessment. And then I also wanted to pick up on his point about avoiding inefficiencies in this process. We have an obligation to make sure that we're using the considerable resources that we have efficiently. And Andrew's presentation reminded me of another presentation I was able to listen to recently from the Bill and Melinda Gates Foundation. They've got a DAC program, I believe that's data analysis and communication. And one of the things that they use to motivate their program is to talk about the concept of uninformative research. And they talk about how many studies, particularly clinical trials, are either so poorly designed that they never have a chance to generate the kinds of results that would inform regulatory and clinical decisions, or they aren't executed properly, or they aren't powered sufficiently. There are so many ways that well-intentioned studies, whether they're interventional or non-interventional, can go wrong. And that presentation just reminded me that when we're doing this work, we're often under tremendous pressure to get the results out fast and to do it quickly. But if it's not well designed, we might spend a lot of effort and time and not get anything that's going to be useful. And so I just think we should always keep that in mind as well. And I think I'll stop there for any other comments or questions.
Wonderful point. I think a lot about the paper some of your FDA colleagues put out a few years ago about the inadequacies in a bunch of COVID trials. So really glad you mentioned that. We got maybe about 10 minutes for discussion. Is there any questions in the room? I've got a few here on my list, but want to make sure we get to the audience before we run out of time.
Can you talk about when and if there will be opportunities for public access to this kind of information? Because I know the price of it is stratospheric. So is that opportunity planned or will it possibly exist in the future?
So, yeah, I can start. So from the very beginning, one of the principles of Sentinel was that we were going to make all the results of all our analysis transparently available. So I think Darren in his presentation mentioned this morning the hundreds of analyses that were conducted and that all those analyses are posted on the Sentinel website. And they're posted in a lot of detail. So anyone could go to that website and look at a particular study and even download the information. There's already a lot of transparency and public communication. Then, of course, if a finding of a Sentinel study is integrated into an FDA decision, then that is also publicly communicated. So I think the question that you might be asking also is, what about the data itself? And the data itself is owned by these various data partners. And so it would really be up to the data partners to decide if and when that data could be released.
And I'll just say a couple of words from the BEST perspective. We also post or publish the results of the analyses that we conduct to make sure that that's available to the public. We have a similar model to Sentinel, that the data is owned and maintained by the data partners. And so there are certainly no restrictions on other groups working with the data partners, other than, of course, having the resources available to fund those studies.
And I guess just one other thing to add there is that so a big chunk of data that Sentinel uses is Medicare data. And Medicare data is publicly available. So that's already available to, I think, the public.
And with that as well, noticing that the data costs are the data costs for Medicare, which is publicly available, and the other data sources. Reagan-Udall has opportunity available in order to be able to access the data if you are not at FDA. And Carla and her team are amazing, and working with them, they really do help to navigate the system so that you can get queries, get understanding of what data might be available in order to move forward there as well.
Thank you all for that. Got a question coming in from the audience. Any plans to coordinate Sentinel and BEST efforts with the emerging rare disease efforts at FDA? And maybe a similar question for others on the panel. Is there a role for including registries for rare diseases in some of these initiatives to kind of support this rare disease work?
I mean, I can start off on that. So thanks very much for that question. It's in the early days with dealing with rare diseases. Some of you may have heard of the Rare Disease Hub that has recently been stood up, that is a joint effort between CDER and CBER. And I can say that there's frequent communication between the BEST and Sentinel teams. So I think going forward with the Rare Disease Hub and the communication that we already have, that might be possible, but we don't have any plans that I'm aware of in place currently.
Does anyone else want to weigh in on rare disease registries in this setting? To that question? No? Okay. Maybe one more question. I think we're getting close to the end of our time. We have a nice bit of folks with international perspectives here, so I wanted to ask a little bit about the role of international collaborations in the future of safety monitoring and regulatory oversight. Obviously pleased to have Patrice here, but does anyone want to comment on kind of, as we look forward, opportunities for more international collaboration in these types of efforts? Andrew?
As an international pharmaceutical company, it's so valuable to be able to do analysis and look at data internationally. I think the different healthcare systems, the differences in populations, all provide opportunities for enhanced safety signal detection and analysis. And I think harmonization and insights across different geographies is just really important.
I can add a couple of things to that from my perspective. The FDA is involved in many international collaborations, including working with ICH to develop more harmonization across the different countries that are a member of that. We work with CIOMS to develop some international guidances. But I really want to talk about what I saw during the COVID-19 public health emergency. we quickly put together under the auspices of ICMRA regular opportunities for the international regulators to meet and share information about what they were seeing with the COVID-19 pandemic and with any safety signals that they might be seeing with interventions that were being used. And I participated on many of those. The cooperation, in my view, was exceptional, and I think it really made a difference in how the world responded to COVID-19. So I do think we have a number of mechanisms in place to help with that, and that it's been very helpful already.
Patrice, did you want to weigh in on that?
Yeah, if I may add to what you said, because we're working on the same groups, and based on the lesson learned from this COVID-19, I will say we have decided also to continue the collaboration on public health emergencies. So we are working currently with FDAAA Canada and 15 other regulators worldwide, including the WHO, to be more ready, I will say, in case of public health emergencies to come, and also to look at safety backgrounds for vaccines, safety backgrounds for some of these diseases, based on the governance and the processes that we are working on currently. And ICH for sure is critical for the work, also trying to harmonize and converge between all the different regulators.
Great, thank you. We are a little bit past our time, so I think I might thank our panelists here for an excellent discussion to help close out the day. And I will hand duties over to my colleague, Garrett Hamre, who I do not see. There, over here, behind the podium. Hand it over to Garrett Hamre to bring us home.
Good afternoon, everyone. My name is Garrett Hamre, Research Director here at Duke-Margolis. Short, mighty, white, blonde-haired gentleman in a blue jacket. I'm going to keep this brief for a couple reasons. One, we've covered so much material today, as we do annually at Sentinel, and I frankly couldn't distill things down much better than was achieved in the last panel. But throughout the day, and as we close now, a couple things always stand out to me when I'm here, and I've been to quite a few of these through the years. The combination of technical, data-heavy, operational, scientific, and collaboratory needs to make something like Sentinel work is really, really incredible. The actors involved, regulators, payers, health systems, drug developers, go down the line. Also really incredible, we have such a hard time in drug discovery and delivery. We have such a hard time in healthcare access. So much of that comes down to the difficulty of bringing so many different actors together on such complicated work. Every year at Sentinel, I feel like something's kind of possible because you managed to do that. So in that regard, sincere thanks, round of applause to anybody who was on the days, in the audience, or the 1,000 or so online around the globe who all contribute to making that happen. Last thing I'll say, capturing a lot of what was stated in this last statement, in this last session. Listen, it's not easy and it's resource intensive, incredibly so. That's always been a challenge, and it's a challenge that seems to be getting harder with each year, kind of maybe each decade. So also sincerely so impressed with the ability to prioritize, try and make things efficient, try and determine where you get the most juice for the squeeze, when you make determinations on what the right question is to ask, putting together a nice plan for answering that question, et cetera. Also really, really incredible, and I always kind of get that sense when I join you all. Really, the last thing I'd like to say, we've covered thanks for a bunch of folks that are involved. It's the folks that you don't see unless you're working on this for the last 4 to 6 months, but I have the pleasure of seeing them. On the FDA side, we've got all sorts of folks that we engage with on a daily and weekly basis. Also in Duke-Margolis, teams hiding in the back, whether it's Kristen Potziad, Matt D'Ambrosio, Hannah Vitello, Luke Durocher. This incredible staff at the National Press Club that makes this all look so glossy and perfect and efficient that you couldn't believe it. I just really want to sincerely thank you all, because you're kind of the unsung heroes on these planning teams, et cetera. And thanks for everything that you do. Can't wait to see you in about 12 months.